Good morning, ladies and gentlemen. It gives me a greatest pleasure to welcome you today to the World TB Day 2023 academic program on behalf of the Sri Lanka College of Pulmonologists. To chair the session, I cordially invite the President of Sri Lanka College of Pulmonologists, Dr. Bodhika Samarasekara, Consultant Respiratory Physician, District General Hospital, Nigambo, and Dr. Geetal Pereira, Consultant Respiratory Physician, Sri Javadanpura General Hospital. Now, I cordially invite Dr. Bodhika Samarasekara, the President of Sri Lanka College of Pulmonologists, to welcome the audience.
Good morning, my dear teachers and colleagues. On behalf of the Sri Lanka College of Pulmonologists, I warmly welcome you all for the World TB Day program, academic program 2023. It is my pleasure and privilege to address this wonderful gathering who are rendering a great service to combat TB in our motherland with an aim to end TB in year 2035. Can we do this? Yes, we can end TB. That is the WHO theme for year 2023. We need to break all barriers and work beyond borders to achieve this target. The Sri Lanka College of Pulmonologists are also working under the theme of Beyond Borders for Better Breath in year 2023. I'm sure we can work together to deliver TB-free breath for people of Sri Lanka. I'm sure we can work together to achieve that target. Respiratory physicians, along with the NPTCCD TB campaign, are playing a leading role to combat TB in all 25 districts in Sri Lanka. I appreciate the hard work of all stakeholders, the TB campaign, the respiratory physicians, and all medical officers during those 2 years of COVID outbreak. We had to work hard. We lost some cases, case detection also, to around 6,000. Now, fortunately, we are achieving again the 8,000 target. All stakeholders done a tremendous service in case detection and delivering medicines sometimes to the home during this difficult period. In spite of all difficulties, we could achieve like 2 guidelines. Firstly, we could complete and publish latent TB guideline. And that was a very successful thing, and I appreciate the hard work of two coordinators, Dr. Shanta Pereira and Dr. Dushanta Madagedara, for helping us and leading the team. And also we are working on EPTB, extrapulmonary TB guidelines. Dr. Dushanta Madagedara is again coordinating. So as seniors, they are committed, and especially Dr. Madagedara, who is here, who comes very early in all guideline meetings, and today also he's at time, and for all the way from Kandy. Thank you, sir. Today we have an excellent academic program covering all the important topics, and experts in the field of tuberculosis management from all parts of the country are delivering these lectures. I appreciate the hard work and leadership of Dr. Shanta Pereira, who organized this academic program on behalf of Sri Lanka College of Pulmonologists. I wish all expert speakers and audience for a very successful World TB Day academic program. I'm sure this will help to achieve our ultimate goal of patient care and TB care. Yes, we can end TB. Let's work together to achieve this goal. Thank you very much.
Thank you very much, sir. So to start the sessions today, I cordially invite our first speaker, Professor Dushanta Madagedara. He is the Chair Professor of Medicine, University of Wayamba, and Senior Consultant Respiratory Physician, Teaching Hospital, Kandy. He will talk on dilemmas on diagnosis of tuberculosis. Over to you, sir.
Good morning. First of all, I'd like to thank our college and Dr. Ishanta Pereira, to organizing this academic program on the event of World TB Day coming on 24th of March. Here, I think today the lecture series is addressing mainly on the clinical areas and the clinical topics, which will be going to facilitate you on your day-to-day management, as well as the updating your current knowledge. Right. So today I'm going to talk on this common practical important lecture on tuberculosis dilemmas in diagnosis, because that's very important as a practicing clinicians and the doctors should have some clear idea about what is happening. As you all know that tuberculosis, we are not going to give you about the basics today. We are going to talk on the common areas. You know that tuberculosis as a group, we can classify this genus Mycobacterium into Mycobacterium tuberculosis complex, where the Mycobacterium tuberculosis, bovis, Mycobacterium africanum come under one group. They share the similar clinical spectrum. And there's another group called non-tuberculous Mycobacteria group, where the NTBs. This has several subgroups. They also the group of Mycobacteria, and they have a different involvement, the different tissues and the different clinical spectrum. And as well as Mycobacterium ulcerans and Mycobacterium leprae, it's another two groups. So we are mainly interested about this group and this rare group of non-tubercular. It's not that rare actually, but here today we are actually concentrating on Mycobacterium tuberculosis complex. Now, what is important in the tuberculosis? Main objective for the TB control activity, we have to rapid diagnosis. Rapid diagnosis. Why it is important, rapid diagnosis? If you diagnose only properly, quickly as possible, then only we can treat the patient properly. So the rapid diagnosis is very, very important, because otherwise if you delay the diagnosis, the spread is there, more morbidity and more mortality and complications comes there. So the early diagnosis and rapid diagnosis is essential, and a specific diagnosis is important. But we need to diagnose tuberculosis. We will come a little later, my slides. Specific diagnosis. We have to diagnose this is a Mycobacterium tuberculosis disease. Otherwise, we assume to be TB and we treat the several patients considering as a TB, but it is not TB. The specific diagnosis is important. So rapid diagnostic methods are very important, because that is give us the quick diagnosis. So I'm not going to discuss the microbiology today, where the clinically suspect histology and microbiological diagnosis are very, very important. When you talk about the diagnosis of tuberculosis, you have a spectrum of lectures today, where the latent TB infection diagnosis is important. That is a disease which is immunologically positive but not having the clinical disease. We call latent tuberculosis. We have, as Bodhika said, we have produced a guideline on latent TB. It is there. All of you can go through. It took some time for us to do it, but we did it. It's a latent. So where we diagnose by a Manto TST and interferon gamma T. There are good and bad things about all this investigation. So the latent TB diagnosis is also important. The current concept of World Health Organization is we have to get rid of all latent TBs. If you keep the latent TB, one day they become active TB. So the seeding and the budding of this latent TB become active TB. If you want to eradicate the TB from the society and the world, we have to treat the latent TB. If you don't treat the latent TB, and at least 1/10 of the patient, at least 10% of the latent TB will become one day activate to seroconversion to active TB. If you have HIV, it's roughly about 50% will can have activate the latent TB into active. If you have a immunosuppressive like say about TNF alpha blockers or patient the rheumatoid biological treatment, at least 25% will become active TB. So it is very important to treat the latent TB if you want to eradicate the TB from the society. And to diagnose active TB is very important. So there we have the commonest method that we have smear and the various cultures and the epidemiological purpose, we do the respiratory treatment, what called Beckman problem. There are so many microbiological investigations, including spoligotyping. We are for epidemiological purpose. I have done a lot of research on that, published also, and these are on epidemiological basis. We can diagnose how the TB epidemiologically behave in the different different straining and the American or Chinese, so many strains. So for the smears and the solid and all the things are helpful us to come to microbiological diagnosis. And we have a rapid diagnostic method for molecular method, including gene experts. So all these things will help us to come to diagnosis. Now the 2013, there's a WHO give us the new classifications. Earlier we said the TB suspect, it came as a presumptive TB, you suspect. These are wording, the presumptive TB. Okay. The 2013, this new classification came quite some time before now. And then another important thing is we have to come to the bacteriologically confirmed TB. That's the most important thing. When someone has a TB suspected, we have to confirm bacteriologically. How we come to? We can do the smears or the gene expert or the cultures. So these three methods, we can come to the bacteriologically confirmed tuberculosis. Other one is if you have no bacteriological confirmation, you have reasonably gone through the patient, reasonable investigation done, you have ruled out the all possible causes, then we come to so-called clinically diagnosed TB. So TB, we can come to one of these three groups. So suspect or clinically diagnosed or bacteriological confirmed. Now I'm going to take only one or two slides for just to give some information. The smear is very, very important for us. It's a common test where all of us are doing. It is given a specificity. If you have smear positive, it's a specificity of 95%. And it's a rapid and inexpensive method to diagnosis of TB, country like ours, where the third world countries, and Asian and African and South American countries, where the smear is very, very important for us to do because it's a very cheaper method and a rapid method. It takes only few minutes. And it's a sensitivity between 25 to 65%. And the positive predictive value for TB depends on the epidemiological situation, where how the epidemiology is there. And we have fluorescent and the seal nascent test. We do the three smears. Each smear, if the third time, it gives the more catching up the more sensitive because we can get almost here the first smear is 80%, second one 10%, third one is 5%. So when you do three smear, that's why we do. Even first smear itself, sometimes there may be contaminant also. And does not allow the species identification. We can't just do in a smear positive. We have a acid pass rods that we can't say which type of microbacteria that we can't tell, but we can't recognize it. And not applicable all sample because if you take sometimes CSF, for example, you can have very few microorganisms. We may not get a positive. So that smear may not be that positive, helpful in the CSF, for example. If you do that just a reactive pleural effusion, we have very few bacteria. It's a reactive. We have few bacteria. That may not give positive. So not that all the sample can be utilized for a smear. An excellent diagnostic test for control the high incidence setting, particularly countries like ours and particularly the countries where there's a more TB. And smear microscopy is insensitive. It detects roughly 50% of all active cases of TB and 50% children and HIV. Not that all TB patients give you the higher yield. So normal TB, 50% and the children 20 and the HIV also. So when it becomes children and pediatric age group and the HIV patient, the yield is less. Recent advance like that new development of the light emitting technology that will give the better yield, better microscopic yield. Another important thing, the same day thing. Now we do the 3-day sampling as usual in the all the chest clinic. We do the 2-day one and the second and third day sample. I don't believe this. I don't believe this because it is not practical. Patients should come to 3 days. And I have done a study, same day. 3 samples, same day, finish it off. We have published a paper long time before when my Damit was my senior registrar, I think they my registrar. So it has given the better yield. So we can't, but only thing that then the workload of the laboratory will be exceeding the limit. That's the problem. But asking patient to come 3 days, transport cost, timing, waste of timing, so many practical things. Why we should go for 3 days? It's absolutely useless. Better do 3 days. We have to go 3 samples because then the better sensitive, otherwise the contaminant and so many other practical problems can be settled. So I actually believe the same day, only practical problem was there with the number, but if you really want to do, we can do it. So this smear is a good test. Country like ours, where the resources are limited, particularly in the economic situation. Now if you have a smear positive patient, we have what? Now, do you think only the mycobacterium tuberculosis complex gives smear positive? No, answer is not. there are so many other organisms. Even all other mycobacteria can give a smear positivity. And these actinomycosis, this group, nocardia, and they clinically behave almost same, also positive. And the Legionella, and the Cryptosporidium, Isosporidium, Cyclosporidium, all are smear positive, acid pass positive. And some parasite like a Sarcoptes, Taenia, and Hydatid, all can give positive. And blastomycosis, histoplasmosis. Now you can understand that even if you are a patient with a typical TB clinical spectrum, smear positive, but still it could be non-TB. That's very important to understand, particularly people who are going to become a respiratory physician. Because even a clinical spectrum, there are even a smear is positive, still remember it may not be a tuberculosis. It is important for your management. The cultures, we have different cultures, which all you know. Conventional egg-based solid cultures, we have the Olivacin and Ogawa. It takes long time, 3 months. So it's really long time, because that will change the patient's complete clinical spectrum. And we have a liquid-based culture. These are take a short period. There are many types. And the Bactec and all these are the liquid cultures. It gives a very early results. Very, very important practical aspect to treat the patient. And roughly about 10 to 14 days, we can get a liquid culture, up to about 20% more sensitive than the solid culture. And there are different other types, actually, because I am not a microbiologist. So there are different types available. So we can give quick, early results. And some tests we can give about 15 minutes, highly sensitive and specific. So there are a lot of new microbiological development. Country like ours, we need to get this new development to get early diagnosis, quick diagnosis, and specific diagnosis. These three are very important. So important. And not only that, we can get the other genotypic identification method like a PCR, LAM, and the Ligestin reaction. These are there, and the fast plaque TB. There are a lot of phenotypic and genotypic investigations are available. That is very important for diagnosis. And the gene expert, the expert is available now last several years with our practice, with sometime with a limitation, some situation. It's very, very important. The results can be within about 1 to 2 hours, 1 hour and 45 minutes. Within 2 hours, we can get a gene expert results. What is important there, the sensitivity is 99%, specificity 90%. It's very important for us. Gene expert positive means the gene expert positive. It's a mycobacterium tubercle. It's a genetic. It is not like a smear. Smear positive means there are many causes can give a smear positive. But gene expert positive means you are 100% certain that you are dealing with the cases of mycobacterium tuberculosis. That's very important. That's important. An expert and give other idea about the rifampicin resistance also. And the line probe assay is another development. It's available in Sri Lanka. These two, not freely, but we have the limited, we are available. It is very important giving results of 5 hours, 60 to 95% sensitivity. And if it is negative, still roughly about 60. And as it pass positive smear, line probe assay will give us almost 95% positive. So these facilities must be used, but should be freely available, but we should not allow to abuse it. And that's, I think, lecture mainly talking on this part. The latent TB is important. Latent TB diagnosis mainly by, I told you, they do not have a clinical symptoms or these pathological changes, but they have the immunological positivities, where the Manto is one common test what we do, and we have a serological test. So the common test what we do is a Manto. It's freely available in our clinic, our government service, and even private service. And the serological tests are limited and expensive. But they all have an advantage. But we have done a study sometime before again. It is in our practice almost equal. We can be used, freely we can use a Manto testing for day-to-day practice. No need for the serological test. But serological test has some advantage. For example, no booster response. And the more closely associated with the recent exposure than the TST. They may have a lower sensitivity than the TST for past infection. So there are some advantage of the serological test and do not require a second clinical contact. Because these are just you take a blood sample, then and there finish it off. You have to do it, there are traumatic things, and you have to come and read it after 72 hours. There's so many practical problems are there with our Manto testing. Better sensitivity for HIV-infected people and the patient with extrapulmonary TB than the TST. Because you know that the Manto testing has I am not going to do a simple basic thing here. It can become negative in many situations, including disseminated TB. So the serological test will not affect in that way. And HIV particularly, you can't have mantle testing, it will be negative anyway, because any immunosuppression, the problem of the cell-mediated immunity, even with the LDLs and the poor subcutaneous tissue, your mantle test will be negative. And if you don't read them properly, if you don't do the proper technique, if you don't take the exact quantity of the mantle, it will be negative. So if you do the interdermal versus intermuscular, anyway it will be negative. You have an unnecessary problem also. And they do not discriminate between the active and the latent TB. Okay? And the blood test T-spot of the quantiferon can be used. And the positive results, T-spot 38% versus quantiferon is 26%. These are statistically significant. Both blood tests have a similar overall agreement with the skin test. Okay? And these are some simple theory you all can read up. The blood tests were better than the skin test in distinguishing BCG vaccinated individual from those with a true positive results. But the cutoff point of the mantle will actually deviate on this particular thing. So what you can tell is that latent TB can be diagnosed by these two tests, where there are advantage and disadvantage. But a country like ours, the mantle test is quite satisfactory. We can manage that except in the few situations where we may need to do a serological testing. It's very expensive in the current practice. Sometimes we can get indeterminate results, 11% in the quantiferon versus 3% in the interferon. Then we do the histopathological sampling of some organ involvement, maybe a pleura, maybe skin, any organ involvement. We are particularly look for typical granulomas with a central necrosis. Caseation methods. We can typical granuloma, we all learn in your pathology. But what is important to understand that there are so many other causes can give the caseating granulomas. Like a protein is caseating, give you not only TB, the syphilis, some fungi, histoplasma, cryptococcus, all will give a caseating granuloma. So someone having the caseating granuloma with a typical clinical history, with a smear positive, it still could not be a TB, mycobacterium typical disease. That's also particularly the senior registrars who are going to be a respiratory physician, remember this particular information. And we do the biochemical investigations. We do now for example, serous fluid. So we do the serous fluid with the pleural or ascites or CSF, whatever serous fluid or pericardial, we do serous. But you have to understand that initial part of the involvement is a neutrophilic. So just because you are having the pleural effusion with the neutrophilic exudative pleural effusion, do not think that it is not TB. It is a TB, but early stage of TB. Same way for CSF, same way for ascites or pericardial. So that's very important. If you become a little chronic, then you can get a monocellular predominant, like a lymphocytic exudative pleural effusion. But just having exudative lymphocytic pleural effusion, do not think that it is TB. Because when we were registrars, when you get exudative lymphocytic effusion or any pleural, unless proof otherwise, tuberculosis. But when we became a consultant, we practiced first 1 or 2 years in that same concept, but we thought that it is totally wrong. Totally wrong. We are misdiagnosing as a TB, the lymphomas, malignancy, so many sarcoidosis, rheumatoid and chylothorax, and even after CABG of a left-sided pleural effusion. Just having someone has lymphocytic exudative pleural effusion, don't jump and say, this is TB. Absolutely not. Absolutely not. I never start a treatment unless I have everything satisfied with me. Just because of that, no. Answer no. Because you are treating lymphoma, Hodgkin lymphoma, as a TB effusion. You are misleading the diagnosis, you are delaying the diagnosis, you are unnecessarily giving unwanted medication with a lot of side effects. So don't think that just because exudative lymphocytic, is this TB? Answer no. Another important test called adenosine deamine. This is one of the biochemical marker helpful in the serous fluid examination, even blood. Adenosine. So activity in the serum and body fluid, we can check it and plays an important role in the proliferation and differentiation of lymphocyte, particularly T lymphocyte. So it is lymphocyte activity is very important for us to have a high ADA level. But increased serum activity can be seen in the many other diseases with a cellular system, like a typhoid, infectious mononuclear, liver disease, sarcoidosis, leukemia, brucellosis, and particular brucellosis, leuk, and so many kinds. Just because of the ADA high, don't think that it is the ADA. But if it is very high, it is supportive. Now the test, radiological, chest X-ray, and all sort of radiological investigation we will carry it out. But none of these radiological investigation is specific for TB. I do not have time for you to, if I say chest X-ray, I can do 101 causes of mimicking any TB. Same way the invasive investigation we will carry out, very important for diagnosis of TB. Now, what is important, the TB in this country and even other countries, overdiagnosis. You overdiagnose. Someone coming with high ES and PUO, you think it's a TB. Someone in the lymphocytic exudation is a TB. It's wrong. You cannot have overdiagnosis. Same with underdiagnosis. The obvious TB, at the moment I have a patient in my ward, young man with the common CNS TB, delayed transfer from the neuralgia. Now he is having the bowel lowering weakness. It is an underdiagnosed. It's very, you can't underdiagnose because particularly pediatric age, if you underdiagnose, the consequence will be dangerous and there will be a lifelong morbidity and mortality. And the delay in diagnosis, very bad. You cannot delay. If you delay the diagnosis, there will be permanent consequences that will lead into death and the incorrectable or unrecoverable definition. The dilemmas are what? The situation where the difficult choice. In clinical practice, there are many dilemmas when you're tackling the cases. So you have to be very careful. So you can't have dilemmas. You should have very clear clinical ideas, come to definite diagnosis. Now I have to go to the next few slides, I think pass. I think I got a little late, first few slides. The pulmonary TBs. Now I told you now there are several situations you can understand that. Chest X-ray is not specific. There are so many tests not specific. So patient come with a pulmonary TB. So then how are you going to do it? Now, someone has sputum positive pulmonary TB, you start standard treatment considering TB, but they are not improving. So then what are the things you have to consider? Now you are thinking what to do. Now patient has sputum positive, TB is having lung cavities, clinical spectrum correct, contact is C+, but you have started it is not improving. Think about the general causes. There, I am not talking about their drugs and quality and etc. I am not going to. And another important, drug resistance you have to be considered. Are there mono or multi or extensive or pan-resistant drug? Are you dealing with the cases of drug resistance? If you are not, but you don't do a drug sensitive pattern all the time, we do a smear and that one. Dual diseases. You may have a TB with a lymphoma. So then you treat the TB, but the lymphoma is continuing. Understand? So, and the paradoxical reaction, early parts of the TB, like particularly CNS TB or even the chest TB, lymph node TB, they become worse at the beginning. Don't think that it is not TB, it is TB, but there's a paradoxical reaction to immunological reaction. Drug side effects. Now you start a TB with a pulmonary infiltration. Now you treat the anti-TB drug, patient clinically. Now you see that new infiltration appear. It could be simple due to your rifampicin or your drugs causing eosinophilia, causing the drug infiltration. So your treatment per se can cause a similar picture. Or even your anti-TB drug per se can cause a BOOF, bronchiolitis obliterans organizing pneumonia. You treat the TB, now patient is starting to improve, now become worse because patient become dyspneic, chest X-ray worsening, clinically worsening. Now you, oh my God, what to do? It may be your drug itself causing the BOOF. That is one having now new chest X-ray changes. So don't think about this. You have to think about these possibilities. And the coexistence with other TB infection. Maybe mycobacterium TB with atypical can be coexist. So you are treating one, but you are not treating other one. So because of that, do not expect one. And if a patient is already having a clinically diagnosed patient, but negative TBs, what has happened? Then if you can't say negative TB unless you are reasonably investigated and ruled out all possible differential diagnosis. So the inadequate and other mycobacteria, you are treating TB but patient having the atypical. Infiltrative disorders like a lymphoma or maybe a vaginous, maybe even SLE, all can cause infiltrative that you may be treating as a TB. It's wrong. Malignancies, for example, allele cells here, you are treating as a consolidation. It is not a TB, it is allele because you are clinically diagnosed. Very, very important thing about it. Hematological malignancies, all lymphomas, very, very common, particular pleural low, CNS or whatever. Drugs. We treat a TB having pleural effusion, pulmonary impairment, very ill, contact is also there or not. But you have forgotten that, go through his drug history. There are some antihypertensive drugs giving as a typical TB in normal. I had a patient like that some time before. Effusion, everything is there. When you stop the drugs, everything disappears. Everything disappears. Other chronic infection, we come a little later, and BOOF. I have seen a lot of BOOF patients are treated as a TB. Because bilateral pulmonary infiltration, lower sound impact, very high ESR, very high CRP, very short test for 2 to 3 months. It is a BOOF, not the TB. So you have to give anti-TB drugs. And extraparent TB is another important thing, a very, very important thing about, because sometimes you will not have definitive microbiological diagnosis. Because time factor, I have to be cut down some slide. So for example, this is one of my patients had a unilateral pleural effusion, typical history, and the CKD, diabetic, and all sort of stuff. They are unilateral effusion. And every investigation we have done, all were negative. So like this is such a chest X-ray. So we had a effusion. And then we had to start a treatment, high ESR, all are high, no other causes, but general investigation can find out. So this is what a CT. If you find this type of CT, irregular, nodular, circumferential involvement, it is malignancy, not the TB. So I did, this is some thoracoscopic appearance in all of my patients. If all infection, even yesterday, if you do not have a fibrous band, there's no loculation, no extensive fiber, it is not a TB. So this is, for example, this type of nodule, yesterday was we did it, it's a malignancy. You may have start some quickly because of clinical spectrum, but you had to use, what I will tell you, all investigation come to the definitive diagnosis. Okay, I take a 1 or 2 minutes quick, otherwise I mean finish. Genital TB is another important, very difficult to diagnose. Genital TB is not that rare, and I just using some of you to just to explain how uncommon form, but you had to diagnose 5% of all female pelvic infections are due to TB. So very difficult to diagnose, Even they can cause infertility, they can cause sometimes the several local complications, infection, destruction, and there will be permanent changes. So then you have to go to the total clinical picture with your colleagues, and then come to the use all the investigation, Manto, even a gene expert, if you want to get a VOG's support to get a sample from the DNC and DNE, all you have to use this. But try to get a definite diagnosis, because you are not giving wrong. Otherwise, joint and spinal TB. The bone TB mimics so many other diseases. So what is important thing? Think about all possible causes of joint TB. This is some differential diagnosis I have given. This could be a pathogenic osteoma like a staph, maybe a typhoid, brucellosis, fungal, or malignancy. You have to think about, try to get a tissue diagnosis before you come to final diagnosis. Bone TB is difficult, not that difficult, but you have to have extensive investigation. But you have this type of features. Time is not permitting me to go detail. There are some specific features of bone TB in TB. You have to go through the specific skeletal features. CNS TB, you have another lecture on that, because very important. What is important? There are many different diagnoses. I told you this sarcoidosis, SLE, lymphoma, HIV, all mimic, all malignancy, mimic TB. That you have to understand that. And the paradoxical reaction you have to remember. CNS TB, at the initial stage, particularly if you have a tuberculoma, cause a paradoxical reaction. Don't think that is some other disease, but you have to understand. So that's why we use the steroid. And delay, if you cannot delay the diagnosis, because if you delay, it can cause a permanent damage. So considering all, that's another topic on the CNS TB, think about it. Skin TB also not that rare. But there are many diseases mimic, starting malignancy, fungal, rare fungal infection, chronic infection, all, even SLE, leprosy, all will mimic the TB. But remember to get the tissue diagnosis by getting biopsies, smear, cultures, and gene expert. Pediatric TB is another thing. Very important to go into detailistic contract and go to the total clinical picture with the support of the pediatric. Now we have now pediatric pulmonologists, easy for us now. So, but remember, diagnosis pediatric TB is not that easy. You have to go through the detail. I just mentioned because there are topics on that today. The PUO. What I want to tell you, you have to get a detailed clinical, I'm not going through this, detailed clinical history. Go through every possible thing to find out the contact, ruling out all other possible causes. Endocarditis, chronic infection, malignancy, everything, hematological. I had to come to diagnose. Sometimes for delaying cause a problem, we may have to start as trial basis, clinical diagnosis. But the clinical diagnosis TB means you cannot just give anti-TB and forget about it. You have to very closely monitor. Every 2 weeks, that patient should see every aspect, clinical, radiological, biochemical, and every aspect. Now, this particular case, try to highlight this patient referred to me from the propionate peradine to start anti-TB, the PUO. And when you go through, we had done every investigation, everything was negative except the ES and some CRP. Only one history gave, there are some animal contacts. So that I think that these people were my SR, that's those days. We diagnosed brucellosis in this case. So when we treat the brucellosis, fever disappear, everything is a police officer. So the only thing what we got in the history, there was an animal contacting Anuradhapur, that's all. Everything investigation was negative. Then we immediately did the brucellosis antigen, became positive, and then 1 or 2 slides. Okay, finally I can diagnose the brucellosis, good. So we treat it. So don't jump and start anti-TB bug just because you didn't diagnose some disease. Because unnecessary, we are getting more TB cases, more complication like that. Miliary TB is other thing. Just because you see the miliary modeling, don't jump and say it is TB. There are many diseases mimic. Is it a sarcoidosis? Is it a miliary carcinoma? Is it a histoplasmosis? All are there. All are there, including some ILDs. All are there. Please look for, do all relevant investigation. Don't delay the treatment. At the same time, you're diagnosed, including bronchoscopy and bile and transbronchial biopsy, including bone marrow, needs to be done. Come to the definitive diagnosis, then treat, even bone marrow. Bone marrow, remember, this is a miliary. Every organ will affect, bone marrow will give positive one. HIV and immunosuppression, consider is very important. TB can come with different clinical spectrum, clinical picture, complete atypical pattern. TB mimickers. Now you have to understand up to now, my slide presentation, there are many diseases will mimic TB. So remember that. Don't jump and start TB. Think about all possible. If you have microbiological proven gene expert, there's no question. Otherwise, think about the mimickers and go to the mimicker. And these chronic infection, I'm not going to label, all are there. All are there. You have to diagnose. Don't jump and say, this is TB. No, there are, it may you are taking actinomycosis as a TB. And when you have a combination, TB can be malignancy, TB can be the lymphoma, all combination, you have to be think about it. Last slide, I think. Whenever you have a patient with uncontrolled COPD, bronchial asthma, ILD or bronchitis, think TB can be coexist. If you do not treat the TB in that patient, you are going to kill the patient immediately. When ILD is less ILD, unexplained clinical versus, you know the complication of ILD, you know. Think about the TB can coexist. I have treated many patients, all recover totally. Think about TB, so do the relevant investigation for that purpose. Okay, the last slide. So the final slides. So think about the TB mimic always. Detailed clinical history and examination must. We can't just jump and say because it's mere positivity. Appropriate investigation. You have to use all your investigation, including EBUS and thoracoscopy and all biopsies. And definitive microbiology diagnosis try to achieve always. And the rapid and early diagnosis essential. Therapeutic trial can be used provided that you are closely observe the patient in every aspect. And the dual pathologies can coexist most of the time that you have to think about, and the paradoxical reaction. I think this is the last slide. Sorry, I have taken, I think, 3 minutes more. But any question I can answer. There's nothing called dilemmas, provided that you use your clinical sense and use all available investigation, what is around you, and get the expert opinion whenever necessary. That's all that I can tell you.
Do you have any questions? So I have one question, like,
Yes, sure.
you know, the empyema also have high ADA levels. How do you tackle that in the TB suspecting patients?
Yeah. So that now, for you to have empyema, it should be two ways. It could be coming from the lungs or neighboring organ, maybe a liver abscess or maybe a splenic abscess, or the paravertebral infection or the lung abscesses for rupturing into the lung. That's one thing. So the clinical history will give you some idea about where the problem started, number one. Number two, the TB empyema is a situation where you can have through the lungs, bacterial or TB, or through the part of the general septicemic state. You can have. Or TB lesion can start within the pleural cavity and they propagate fast and causing the severe TB infection. That's how we get it. Now then the clinical spectrum will be same. They both will be very ill, TB empyema as well as a bacterial empyema. They are usually very ill patients. Where ESR, CRP, everything will be high. Clinically, they are almost same. So there, what is important is come to the bacteriological investigation. Now, when you get the pleural aspiration at the beginning I told all will be neutrophil, same way, but the neutrophil count will be very high. CRP will be disproportionately high in the empyema, bacterial compared to TB. ESR will be both will be high equally, and the total white cell count will be disproportionately high in the bacterial empyema compared to the tuberculous empyema. Maybe slightly high, maybe 12,000, 15,000, but TB bacterial empyema will be 30,000, 40,000, something like that. And then simple thing, when you get the split out, ADA will be high. ADA cannot differentiate. Now ADA I told you, so many, including all will be ADA high. Get the basic clinical treating. When you get a smear, when you get a pleural aspiration, we do the basic things, all will be a neutrophilic exudative. Get the gram staining. Get the gram staining. That can be done very simple, basic investigation. At the same way, TB empyema, gene expert will be highly positive, smear will be highly positive. TB empyema means the multiplying organisms are living in the pile. But gram staining as well as our normal smear will help us to quickly differentiate this thing. With others, I will support him. But both we will do the thoracoscopy. We will do thoracoscopy but both will show you the enough multiloculated, complete like a jungle, as a jungle within the pleural cavity. But biopsy will be definitely show in the granulomas and the TB as well as the gene expert, everything will be positive. And I do gene expert, all pleural thing. I do not believe it's a 40% positive. I don't want to miss that 40%. And there's a guideline say, pleural effusion donor, I do. But a gene expert will be highly positive in empyema. So use a simple clinical spectrum, go to the gram staining smear, and the thoracoscopy is must. We never do without thoracoscopy because we had to get rid of all pus within the pleural cavity. Okay.
Thank you, sir. We won't take any other questions for the want of time. Thank you very much for that very passionate lecture coming with a lot of experience, a lifetime of experience. Thank you very much, sir.
Okay, yeah, thank you.
Now I cordially invite Dr. Niranjan Disanayaka, Consultant Respiratory Physician, Teaching Hospital, Ratnapura. He will be talking on tuberculosis in chronic kidney disease. Over to you, sir.
Thank you very much. And it is an honor to follow my dear mentor. And I will be not here if not for him. And I know that most of our respiratory physicians who trained under him will not be here unless for him. And I would like to thank Dr. Shant Pereira for kindly inviting me to deliver this lecture today. So the topic today is tuberculosis and chronic kidney disease and how to conquer the dual challenges. So to conquer any challenge, I think we should understand the basic biophysiological and pathophysiological mechanisms and then apply it prudently so that we will be able to treat our patients properly. Tuberculosis has been with us for the millennia and is a chronic disease that keeps on challenging us in a constant basis. And at the same time, chronic kidney disease, due to many factors like the recent epidemic or pandemic of diabetes and exposure to toxins, have recently been a major important medical condition that we have to tackle with on a daily basis. So if you look at the dual burden of CKD and tuberculosis, in the upper slide you can see that the tuberculosis burden of Sri Lanka is estimated to be about 60 to 65 per 100,000. But we diagnose about 45 to 50 per 100,000 per year. So we are considered as a moderate burden country of tuberculosis in the world. When you look at the CKD, the chronic kidney disease estimates, we are named as a low burden country, less than 100 per 100,000. But I obviously think that this is probably because of the underdiagnosis of CKD amongst us. And you will experience, even in a normal medical casualty, there will be a lot of patients with high serum creatinine coming in, and most of them have acute on chronic renal failure. So probably we are underdiagnosing CKD in Sri Lanka. Hence, the burden that we are dealing with as CKD, it might be much more higher. Hence, the problem of dual challenge of tuberculosis and CKD will be much higher than we actually think. So the challenges I have divided mainly into 4 segments for this topic. One thing is tuberculosis as a cause of chronic kidney disease. The second is the raised risk of tuberculosis in patients with chronic kidney disease. Third is the challenges and the dilemmas we face in a daily basis when diagnosing tuberculosis in patients with chronic kidney disease. It is not straightforward. And the fourth is the challenges that we face in a daily basis of treating coexisting tuberculosis and chronic kidney disease. out of which I would like to go into the first one first. Tuberculosis as a cause of chronic kidney disease. Now, we know that genitourinary tuberculosis is not a very common manifestation of tuberculosis. Of the extrapulmonary tuberculosis, it consists about 5%, 1 in 20 of extrapulmonary tuberculosis cases. And there have been studies in Europe specifically to identify whether tuberculosis is causing chronic kidney disease, and they have identified in a cohort of people 1 in 200 of the people who with kidney disease, with chronic kidney disease as the causative agent being identified as tuberculosis. Hence, tuberculosis can cause chronic kidney disease. One specific and very important aspect of this chronic kidney disease is that the tubular interstitial nephritis, which is caused by chronic kidney disease, by tuberculosis. So there, the ultrasound scan of the abdomen revealed normal kidneys bilaterally, but the patient's kidney functions have gradually deteriorated. Right? And even the UFR had not revealed pyuria as we expect in genitourinary tuberculosis. The tuberculosis has been diagnosed by the renal biopsy when they have tried to identify the causative organism, causative agent or causative factor for the tuberculosis, where the biopsy has proven that there were granuloma which were caseating, and 3 out of the 11 people who have been identified as tuberculosis pulmonary, they have identified acid-fast bacilli as well. So this is in the context of CKDU in Sri Lanka, the chronic kidney disease of unknown origin, which is also a type of tubular interstitial nephritis. I think that we should investigate further into it to see, being a moderate tuberculosis country, whether some of these patients who have been actually labeled as CKDU have actually tuberculous kidney disease, which I think it's a very good research topic that we have to think about. But the genitourinary tuberculosis that we already know is also a challenge to diagnosis, because specifically these patients doesn't have the typical symptoms of tuberculosis like fever, loss of weight, loss of appetite. They usually come with sterile pyuria, persistent pyuria, not responding to the normal antibiotics, obviously, but we keep on giving antibiotics repeatedly in spite of the patient not being responded, and the patient's renal function will gradually deteriorate within about 1 or 2 years. And the second thing is the hematuria, where the patient comes. So if we have a persistent pyuria and a hematuria, I think we have to obviously actively think about the underlying diagnosis of tuberculosis, especially because if it is identified in the early stages, such as we see in this X-ray, you can see the small calcifications, calyceal calcifications here, and then here there are major calcifications here. And here, this patient has developed a stricture and dilated the pelvis. And here, the patient has developed strictures in the ureter, and the kidney, the bladder wall is already thickened. So rather than identifying it late, if we identify the tuberculosis early, we can actually prevent the kidney from going into this state. You can see a lot of papillary calcification, destruction of the kidney, and being filled up with caseous material, TB pyelonephritis. So basically, I think we can prevent that from happening, even though it's a rare disease, if we have the correct clinical approach. Specifically saying that even when the patient's renal functions are deteriorating, if we start treatment of tuberculosis, this bar indicates starting of treatment of antituberculous treatment. You can see that before the treatment, the renal functions are gradually deteriorating, but after starting the treatment, you can see that there is some degree of renal recovery in this patient. So hence, it's very important to identify these patients rather early than late. Intravenous ureterogram and CT pyelogram are being the gold standards of diagnosis, but to diagnose the structural abnormalities, but the bacteriological confirmation will usually come with a tuberculosis culture in the urine, not AFB staining, because there are many commensals that are there in the urine, like Mycobacterium sphegmatis, which might give you a false positive result. Right. So the second important aspect here is raised risk of tuberculosis in CKD. Now, various meta-analyses have shown basically, that when you have chronic kidney disease, you have about 4 times, especially in patients who are being dialyzed, we have about 4 times more risk of developing tuberculosis in a patient rather than in a normal person. But this 4 times has been sometimes has said about 10 times, so depending on the area that you are living in and depending on the article, this might change a bit, but the take-home message is that in a patient who is already on dialysis, the patient has a higher risk of developing tuberculosis than the normal population. And if the patient is a post-transplant patient, we have a 12 times more ability or risk of developing tuberculosis than in a normal patient, which is a very significant factor. And the other important thing is that 1 out of 4 to 3 out of 4 people who develop post-transplant tuberculosis will eventually die. And they will be very, very complicated. Hence, we have to understand this very importantly. Not only the chronic kidney states, even stage 3, that means IGFR less than 30, less than 60, actually have an increased propensity to develop various infections in the body. So our immune system probably start to dysfunction at a EGFR about 60. But we have to identify the most important group as the dialysis patients as well as the patients who have undergone transplant. Now, when we look at the why the progression is, this is the left side one is the T cell dysfunction. This is the whole immune system dysfunction. So if you look at the T cell dysfunction per se, we can identify that at the CKD stage 4 and 5, it is there that mainly the T cell dysfunction come into activity, and because of this T cell dysfunction, the patients will have a higher risk of developing tuberculosis than in the normal population. But when you look at a whole, chronic kidney disease basically because of the underlying cause such as diabetes, as well as the chronic kidney disease per se, causing the defects in the complement system, the neutrophilic system or the innate immune system, as well as the B cell and the T cell system, adaptive immune system, there is a proportional rise between the CKD stage and the patient's risk of developing tuberculosis. Right? So this is a very important, interesting new development that we have found to identify why these patients have a risk of increased immune dysfunction, and there is more interest developing between the dialogue between the gut and the lung, gut and the liver, gut and the brain, gut and the heart. So basically, our microbiome seems to be controlling whatever we do. And hence, the new studies have shown that certain changes in the microbiota in the gut and the enzymes that are changed produces certain substances, and the alteration of the gut epithelial barrier because of the uremia can cause increased absorption of certain substances which can influence the regulation of gene expression and hence the immune function of the body. So this is a very important thing. And together with decreased excretion of what we call PBURS, that is protein-bound uremic retention solutes in our body, as well as the increased production of these substances from the microbiota, we are increasingly predisposed to develop certain activation of the endothelial system. So they activate the endothelin, they increase the vascular adhesion molecules in the vessels, and hence there is increasing chronic activation of the monocytes and the neutrophils, and this can lead to atherosclerosis obviously, but this persistent activation of the neutrophils can cause immune dysregulation of the body, hence reduce capacity of our body to react against infection. And certain substances like indocile sulfate can cause antigen presentation dysfunctions as well as cytotoxic T cell dysfunctions, and hence the adaptive immune system of the body can be impaired, especially in stages 4 and 5 of certain kidney diseases. This is very important to understand because these are the current mechanisms that are postulated because of that. And a person who is being dialyzed, on top of that, because of the dialysate membrane, there is a rapid interaction between our body cells as well as the dialysate membrane, and hence the T cells, they have found that the T cells are number of T cells are reduced, so there's a lymphopenia, and at the same time, the complement systems, all three types of complement system, the classic, the alternative pathway, and the lectin-mediated pathway are activated, and at the same time, the neutrophils are chronically activated, hence there will be a persistent inflammation in our body, not targeted inflammation, but a persistent inflammation, so that the patient will have an immune dysfunction because of that. So how do we navigate this challenge of latent tuberculosis infection? And we have our college, with the leadership of Dr. Ishanta Pereira, had developed the guidelines, and these guidelines are available at the NPCCD site, and it's easy to download. But the most important features that we have to think about is think about tuberculosis in a patient with tuberculosis. Hence, do the chest X-ray and sometimes CT and even bronchial lavage in appropriate patient to diagnose. Consider the two-step TST, that is a MAN2 that we do first at day 1, and then we do the MAN2 in about 2 to 3 weeks' time. 1 to 3 weeks' time. So ideally, in about 2 weeks' time, we do that to see what we call it the two-step MAN2. The reason is that when you give a MAN2 to a person, if the patient has seen this bacteria a long time ago, you might have a false assurance that the TST is negative. But when you do it in 1 year, you might have a positive because of the effect of the MAN2 that we have done 1 year back. Hence, to prevent that false boostering effect, to understand whether this patient is actually having latent tuberculosis or not, to prevent the anergy, especially in a patient with dialysis and chronic kidney disease, it's advised to do the TST once, and then if it is negative, do it in about 2 weeks' time. This is called the two-step TST. And then to advise, because we have heard about the IGRA and the TST, we do both of them together, because some of the TST negatives can be IGRA positives, and the IGRA positives can be TST negatives. Now we have actually a lot of new things developing, interleukin-2 levels, interleukin-2 to interferon gamma releasing assay ratio, and interleukin-3 levels to see whether the patient is having active tuberculosis or latent tuberculosis, and to differentiate between latent and active tuberculosis. New cytokine markers such as vascular endothelial growth factor is coming in and has been proven to be of significant benefit, and we can use it to treatment response as well. So within about next 3 to 4 years, there might be a lot of new developments in the tuberculosis diagnostic armamentum rather than this. So this is the basic graph. Any TB-related symptoms are there. We investigate these patients for tuberculosis. If the TB-related symptoms and the X-ray is normal, we do ideally TST and IGRA at the same time to see. So if either is positive, we treat the patient as preventive treatment. These are the patients who are on dialysis, not the other CKD patients, because we can't treat them at the moment because it's a huge burden. Right. Right, okay. So then if both are negative, TST and IGRA, basically it's negative, we go into the second TST, that is the TST, and then if it is positive, give preventive treatment. If it is negative, we observe. So we really want to catch these people who are having chronic kidney disease, specifically who are dialyzing before the patient develop tuberculosis, because the outcome of patients who are developing tuberculosis is much, much more poor, right? So if the patient has features of tuberculosis, obviously we investigate with appropriate treatment modalities, and then we go, if it is negative, we go in the other pathway, as we said earlier. Right, so when the patient has chronic kidney disease, we know that when the chronic kidney disease progresses, we knew that the patient's immune system goes down. And the patient, especially who is in dialysis, anyway, the immune system goes down. So because of that, the sensitivity of the tuberculin-sensitive test will be reduced markedly at that time. And at the same time, the level of IGRA will also be very low. So because of that, we recommend that this patient, before commencing renal replacement therapy, at least at stage 4, to see whether this patient is having latent tuberculosis or not. Right, so diagnosing tuberculosis in CKD is very, very tricky. This is a patient who presented to us, bilateral pleural effusion. You can see the dialyzed catheter, bilateral pleural effusions. ESR is 45, Saturation is about 88 in air. Diagnosed hypertensive, diabetic nephropathy, hypothyroidism, body swelling. And this is the ultrasound scan. I hope that displays. Yeah, so there is a small, very small pleural effusion, and we did the aspiration, and you can see that it is basically a transudated. This is about 75% of the pleural effusions, which is one of the most commonest ways a tuberculosis patient can come to you, presents like this, a transudative pleural effusion, and hence improving the renal failure part and patient's heart failure and other hypoalbuminemic state will improve the pleural effusions in these patients. But at the same time, this can present in many, many ways. This is another patient whom we had, right? So with investigating for a hemorrhagic pleural effusion, where there was, that uremia also can cause pleural effusions, and when we did the thoracoscope, because we were suspecting of malignancy, this was like that. There were multiple adhesions of this patient. And there is another patient. Fortunately, this patient didn't have malignancy, but this patient, you can see that there were nodules and the patient had malignancy. So uremic pleural effusions can be hemorrhagic, but at the same time, if you are suspecting, we have to further investigate. And these are 2 thoracoscopies that we have done. And sometimes you can be surprised with malignancies and sometimes with tuberculosis. Right. So sometimes it's very good. And in that study, 75 of the patients have been transudative, but out of the 25 which were exudative, about 1/4 of them had tuberculosis pleural effusions. Hence, in a patient who are having a high ESR, lymphocytic pleural effusion, hemorrhagic, patient doesn't improve with treatment, unilateral pleural effusions, not fitting into the typical transudative picture, I think we have to further investigate these patients rather than discarding them, because these patients has a higher risk of tuberculosis, higher risk of malignancies, and higher risk of other complications as well. Right? The other main factor is the continuous peritoneal dialysis. In the patients who are having continuous peritoneal dialysis, they have a very high risk of developing tuberculous peritonitis in these patients. Right? And these are the X-rays that can be referred to you from the renal unit. Multiple opacities. This is the hyaluronidopathy, multiple opacities. And these patients can be TB, or it can be fungal infections. It can be features to suggest that the patient is having other renal impairment diseases. Sometimes it can be a vaginous granulomatosis with pulmonary manifestations. So thorough investigations are much, much necessary in these patients. These patients' ESR is high. MANTO can be negative. Sputum gene expert can be negative. So it's very important to see these patients properly. And sometimes we have to go for a bronchoalveolar lavage as well. Treatment of CKD is very easy. Take-home message, rifampicin and isoniazid can be continued with the same dose, same frequency. Pyrazinamide and ethambutol should be given every 3 days, especially in patients who are having serum creatinine clearance of less than 30 milliliters. Just 1 minute more, Chairperson. Right. So rifampicin, usually we don't need a significant dose adjustment, even in the 30-60, 20-29 or less than 10 group, even hemodialytic patient or peritoneal dialysis patient. But remember, rifampicin can cause a tubular interstitial nephritis, as the drug can cause kidney problems. So we have to be very careful when you are giving a patient. And the second important thing, especially post-transplant, some of these drugs that we give for immune suppression can be metabolized more quickly by rifampicin. Hence, the dose adjustments needs to be corrected. But for the treatment, we really don't need a significant dose adjustment for the rifampicin. INH is the same thing. Isoniazid is the same thing. We can use the same dose, same regular basis. But we know that in patients with renal failure, specifically, they have a high degree of neuropsychiatric problems. They can develop grand mal seizures. They can develop confusion, and they can develop hallucinations and nightmares. So in a patient with renal failure, we might attribute it with tuberculosis, we might attribute it to uremic encephalopathy, but sometimes INH might be the cause of this. And they have a high degree of developing peripheral neuropathy as well. So even though drug-related, we might not have problems directly hepatotoxicity, but the drug toxicity might increase in renal failure. Hence, we have to keep that in mind Pyrazinamide is a very beautiful drug. It actually acts against the bacteria that are there in the macrophage in the acidic environment. But unfortunately, some of these metabolites, even though it is not, it's metabolized by the kidney, but it is excreted. 70% of them are excreted by the kidney. Metabolized by the liver, excreted by the kidney. And some of these substances, the metabolites, such as 5-hydroxypyrazinoic acid, is hepatotoxic. And the half-life of pyrazinamide from about 9 hours increased up to about 15 hours when you have renal failure. Hence, we usually give it every other day, right? And ethambutol is another important drug, which is a bystander, which we don't think about the harmful effects of ethambutol in most of the instances. Especially, ethambutol is a chelator of zinc, and the zinc is very important for the for transport of retinol from the kidney, from the liver to the eye, as well as transformation of retinol in the eye as well. Hence, it's very important for the color vision. And these patients, if the patient has gone into the ethambutol levels that are eye toxic or ophthalmotoxic, they can go into central scotomas, they can develop central scotomas, peripheral field vision defects, color vision defects, mainly in the blue, yellow, or green-red range color vision defects. And if we don't diagnose it appropriately and we don't stop the drug and we don't adjust the dose, these patients can go completely blind, especially the renal failure patients. We have to be very careful about these patients. So visual assessment is a very important thing. Fluoroquinolones can be given without any problem. Right, so this is the take-home message. Especially if you are giving a anti-tuberculosis treatment, it's always better to give it after dialyzing the patient so that the patient's drug level will be there. So I will be finishing my talk basically, but the most important things that we have to highlight is CKD in tuberculosis. Tuberculosis can be a cause of CKD in some patients. And when CKD and tuberculosis coexist together, it has a raised risk of, the CKD per se has a raised risk of developing into tuberculosis. Diagnosing tuberculosis in CKD is a challenge, as we saw, because of the limited clinical presentations that we have and the investigative facilities that we have. And treatment of CKD is not that complicated if we know how to treat them in a proper way. Thank you very much for your time. Thank you, Professor. Yeah.
Thank you, Niranjan. We can take one question because we're slightly behind time. Do we have any questions from the house?
Just thank you, Niranjan, for the excellent talk. And one point I just wanted to raise, one thing now, the dose adjustments we do for CKD patients having TB, and it may not be picked up when those people having CKD and not on dialysis, we having the dose reduction for EZNE, and when they are started on dialysis, on continuous renal replacement therapy, like sort of a dialysis kind of, do we need to still to go for a lower doses, or can we go for the normal doses again?
It depends on the dialysis frequency, isn't it? And usually, what the guidelines says that in a patient who is being dialyzed, again, to give the drug, especially rifampicin and INH, we can give it on a daily basis, as we know. But for ethambutol and pyrazinamide, we have to give it after dialyzing. So usually the dialyzing frequency is about 3 times a week. So what they do, what they say is to give the pyrazinamide and ethambutol soon after dialysis. And one important thing that was highlighted, I think we might have to think about it as well, because especially in this group of people who are having CKD, the use of ethambutol actually. So whether it tends to do more harm than benefit, especially in the intensive phase. So probably as a college, we might have to get together and to decide on that, because we don't have regular screening of vision in these patients. And some of these patients' vision problems might be attributed to old age, diabetic nephropathy, or sometimes even uremia. Hence, I think regarding ethambutol, especially in the context that we have a very good drug-sensitive tuberculosis in our country, I think we might have to make a decision regarding ethambutol unless we have a proper method of having drug monitoring facilities.
I totally agree with you, Niranjan, because most of our patients are having 2 times a week dialysis.
Yeah.
So I think we have forgotten that part. And so when we prescribe medicine, we basically give them the routine like the renal regime, like you said, every other day, and this daily rifampicin INH. So I think the ethambutol toxicity is really, we have not paid much attention.
Yeah, I think we have to update our guidelines accordingly during this. Yeah.
I suppose it depends on how dialysable these drugs are also, because you know, just because you dialyze, it doesn't mean that you get rid of everything that is there, just like how the kidney does it. Anyway, thank you very much, Niranjan, for the usual quality lecture that we always look forward to. Thank you.
I would like to invite our next speaker, Dr. Ridma Jayaratna, consultant pediatric pulmonologist and lecturer in pediatrics, University of Sri Jayawardenepura. Over to you, madam.
Good morning, everyone. Thank you. I wish to thank the Sri Lanka College of Pulmonologists, the council, and the team for inviting me for this talk today. It's been a bit strange when a pediatrician coming and talking in front of the adult consultants and physicians, and especially in front of my teachers. So today I'm going to talk bit about evaluating congenital TB and infants with TB. So I don't think that I have to give a big introduction about the tuberculosis because it is being with us for ages, and still we are trying to combat TB. And then every day we face challenges as clinicians in the diagnosis, management, and following up of these patients. Especially when you talk about the children, it's quite difficult. So because their symptoms are more non-specific, and finding samples and diagnosis is difficult. And when you start treatment, following up is difficult because you have to handle both the child and the parent. So right. So we'll look at the disease burden of the disease. So why we are talking about the congenital TB and the infant TB. If you look at the disease burden among the world, so the total estimate is more than 10 million cases every year. So, and then importantly, 10% of these cases are representing pediatric population. And then every year, 1.5 million people die of TB. So we have to concentrate on preventing this morbidity and mortality. And most importantly, if you look at the highest number of cases representing in this map, so you can see the Asia, Africa, and Mediterranean regions are picking up. And we should be very careful because Southeast Asia is comprising 40% of the cases. So that's why we thought, as in Sri Lanka, we have to step in to control the morbidity and mortality. And then if you look at the mortality among the children from the tuberculosis, so here, though we have a lesser amount of cases per 100,000 a year, still we have a high number of TB cases, and WHO says that you are not diagnosing enough. So we are finding only half of the expected TB cases. So that's why we are thinking where we should step into. So at the same time, now we are challenged with the dual epidemic with both retroviral and TB infection. And again, so 1 to 4 years of age, children representing are battling with the dual infection. And then if we get the HIV and the TB both, they have 20 times greater risk of dying because of TB. But so if you look at the distribution of the pediatric TB, still you can see the majority comprises the children less than 5 years, but retroviral negative. So we have to trace these children find these children and treat promptly to prevent devastating outcomes. So I thought rather than going into theoretical jargons, we'll go with the clinical cases. So this is one of the patient. I got the referral from a neonatologist. So this 26-year-old mother gave a birth at 36 weeks, so quite preterm, and with a weight of 1.6 kilograms. So we would expect average of 2.5 kilo in our babies who when they were born. And then child developed respiratory distress on day 1. So mother had fever on the day of admission. So we think the mother has maternal sepsis and child had distress risk factors for sepsis. So treated as for congenital pneumonia. But child is not responding. Antibiotics have been topping up, but the child is not gaining weight as well. So then the consultant thought she would go and speak to the mother, and then the history came up. So the mother had a history that she's presenting to the outpatient department during the pregnancy period with a cough and fever and chest pain, and then it's taken as ordinary chest infection, treated, there was no response, and then started on inhalers, thinking of asthma, and then, but still there was no response. And then ordered a chest x-ray, but mother denied. And then she disappeared. But she was having persistent cough even at the time of baby was admitted to the, she was brought to the delivery. So, and then we step up and then we did the gastric lavage sampling, but unfortunately no bacteriological diagnosis. And the ultrasound scan of the abdomen was done, and then we found that there was hepatomegaly. But there was no granuloma, but there was one portohepatis lymphadenopathy was found. So the congenital tuberculosis was diagnosed and started on anti-TB treatment. So the perinatal tuberculosis, so often we encounter in the infants where there are mothers who had the active TB during the pregnant period, and so it could be transmitted either from maternal genital tract when they were delivered, or maybe during the delivery, the aspiration of the amniotic fluid which was infested with the tuberculous bacteria, or postpartum transmission through the mother being smear positive. So, but however, to diagnose whether it is congenital TB, so because all the children whose mother was diagnosed have TB during pregnancy does not carry the active disease when they are born. And then, so these diagnostic criteria were brought up, and then we have two main primary and secondary criterion. So in each criterion, so we have to demonstrate Mycobacterial tuberculosis lesion. And then, so either we can show the primary hepatic complex, because in a child, in a baby, in the intrauterine life, most oxygenated site is the hepatic region, because your umbilical cord comes and umbilical vein come and connect to the baby at the porta hepatis. I'm sure you might remember the anatomy. And then, so that is the most oxygenated region in the fetal life. So the mycobacteria grow there, and then you will develop hepatic granuloma. So we see the primary hepatic complex in neonates, and during the intrauterine life, it is in the liver rather than in the lungs. So when you have this criterion, we could diagnose congenital TB. But unfortunately, we hardly diagnose congenital TB based on these criterion, because we do not demonstrate mycobacterial samples, lesions in the samples, because we do not send placental sample, because it's very difficult in the obstetric wards, especially, we do not take the history properly. So as Professor Madhagadra mentioned, the clinical history is a must. So unless you ask, the parents would not say, because it's a social stigma. So they would be worried that they will be cornered in the ward, and they would not be given proper care for their babies. So they would not tell unless you ask them. So it is really important during the antenatal visits to get the histories, and when they admitted for this delivery, again get the history and find out how long they have been treated and what are the medication they are on, are there any complications? Because if we found that they have a history of tuberculosis during pregnancy, it's easy that you would send a sample of placenta for histopathological diagnosis. And then if you think of the common presentation, so they often deliver prematurely and they have fetal growth retardation, they have low birth weight, and then so after born they have feeding difficulties, they would not thrive well, they would not gain weight, and then they will have respiratory distress. So respiratory distress is not a universal feature. So that's what we should remember, because we all often tend to think like if it is TB, they have pulmonary manifestation, but there could be children who do not have respiratory distress, and they would have hepatosplenomegaly and generalized lymphadenopathy, where your lymphoproliferative system is affected, and then often they would complicate with meningitis and disseminated TB. So these are a couple of pictures in the lung, and so you can see the huge hepatomegaly. But when you do the ultrasound scan, you would look at the porta hepatis region and the lymphadenopathy and granulomas in the liver. So the current recommendation, so I would, before going to this slide, I should mention that, so even in a neonate, we follow the same sampling as for the other babies. We would take gastric lavage samples for the smear, especially for gene expert and for the TB culture. So, if you are suspecting meningitis, we would send lumbar puncture. We would do the lumbar puncture and send the CSF samples for gene experts, AFB, and then for the culture. So often the gene expert is really helpful, and it is recommended as the first line bacteriological diagnosis in children. Right. So this is the current recommendation given, guidelines given in the Sri Lanka. So when you have a mother delivered a baby who had a smear negative at the time of the delivery, and then you can give the BCG, and then if the mother has a smear positive tuberculosis at the time of the delivery, then we have to screen the child for whether they are having any tuberculous disease. So earlier we used to say it's the active disease, now we say it's a tuberculous disease. And then if it is positive, you treat with anti-TB treatment, and negative, we would withhold the BCG and give the INH prophylaxis. And after 3 months, we would reevaluate. And if it is negative, the INH is withheld and give the BCG. And if the MANTU is positive, and if, again, you would evaluate for active disease. And there's no active disease, you would continue prophylaxis for another 6 months. So this is the general recommendation at the time we have. And then, most importantly, remember not to forget tuberculosis during pregnancy, especially because they are in an immunocompromised state. So they are more prone to get reactivations. And then there's no contraindication to take chest x-rays during pregnancy. So we should, when we speak to the mother, especially, we should tell them that we have abdominal guard can be given, and the x-ray could be taken, and it has a more benefit of diagnosing the mother rather than exposing the radiation. And then there's no contraindication to start anti-TB treatment during the pregnancy and during the lactation, and you don't have to separate baby from the mother, and you can continue the breastfeeding. So that's a little bit touching around the perinatal TB. So if I go to the second case, so this was a 3-month-old baby. So she was presenting with high spiking fevers, cough, and poor feeding. And then, so the X-ray was taken, and there was a right upper lobe consolidation, treated as for pneumonia. But there has not been any clinical improvement in the baby. So when you look at the investigation as well, so there has been a neutrophilic leukocytosis, CRP96, CSR80, and liver enzymes were normal. All the other enzymes were normal. But when the X-ray was repeated after about a week of treatment, again you can see it still persisting. Then we tend to think like whether there's anything else is going on. And then the CT was performed and found to have necrotizing lymph nodes. So most commonly, the babies, the infants and the younger children, they have extrapulmonary manifestations in the TB, and especially the tuberculous lymphadenopathy peaking among them. So, and if you look at the growth chart of that baby, so this was later traced, and then you can see that child is nicely picking up the weight and start flattening of the growth. So these growth charts are so much sensitive in the diagnosis of tuberculosis. Especially, we would look at the child's X-ray and other clinical symptoms. Most often, the babies, especially the infants, the failure to thrive or poor weight gain or growth flattening, we need to exclude whether there's any possibility of TB. So taking a proper history, looking for the contacts, household contacts is really important when you look into these babies. So as I said, so the clinical presentation, if you think of, so they can present with pneumonia in the airway, and then the lymph nodes, and then the central nervous system. So if you look at the infant age, these are the most common presentations, that is lymphadenopathy and the meningitis in babies. So the less commonly in the babies we would see in the peritonitis and the renal involvement. And then again in the skeletal TB, we would see mostly the hip joint involvement. So they would come in a picture with septic arthritis, and then later, most often they diagnose very late after doing even arthrotomy. Only we would diagnose TB. So it is really important when the atypical cause is there, think about tuberculosis at the initial stage. So it is always, the symptoms are not straightforward. So in babies, in the small children, so when there's poorly resolving pneumonia, complicated pneumonia, and especially when the multi-system involvement is there, we need to take the tuberculosis as a differential diagnosis at the very beginning. So we would not wait till they respond to antibiotics or other treatment. And then, as I mentioned, when there's growth-related changes, and especially when there's underlying immunodeficiencies, that I will speak in the next slide. And in nowadays, in some of our regions, we have immigrants and the displaced population. So when there's overcrowding and when they are living in this disadvantaged environment, we have to think about the tuberculosis early. So this is the third case. So I will try to finish this quickly. So this is again an interesting patient, again coming in at the age of 3 months, but the second born, and developed a respiratory distress at the second week of the life, needed respiratory support. So child was being into the neonatal intensive care for about months, and then the baby was managed as for having a complicated pneumonia and left-sided chylothorax. And then they slowly take off the tube off and then send the baby home, and then coming back again on the next day with a respiratory distress. So then the ultrasound abdomen, there was hepatosplenomegaly, and there was a reaccumulation of the chylothorax. And then later they revealed that they had a baby, again a boy, who was died at 6 months of age with a similar picture, having hepatosplenomegaly and respiratory distress. So that triggered the possibility of immunodeficiency. So the neutrophil function defects was looked into. The NBT was positive. So it was a chronic granulomatous disease. And then when there is atypical causes going on, think about the possible underlying immunodeficiencies, so the congenital neutropenias, neutrophil function defects, and especially the secondary immunodeficiencies maybe when they are older. So when they are on steroid, the anti-TNF therapy, now we do use them very frequently. And again, the retroviral infection. In children, when we diagnose TB, we always confirm whether the child has retroviral therapy before retroviral infection before we start treatment. So this is another interesting immunodeficiency that we discuss among the children. So this is very rare, but it is interesting to know. It is the Mendelian susceptibility to mycobacterial disease. Often when we should consider about MSMD, where they have BCG disseminated disease, and when they have recurrent infections of mycobacterial disease, and then especially the osteomyelitis and the repeated lymphadenopathy. So, normal immunological screening is there. So all your immunoglobulins normal, full blood count is normal, and lymphocyte subsets are normal, and then neutrophil function defects are normal. So in that case, if they are getting recurrent infections, you need to think about the MSMD. So in summary, so neonates and infants with tuberculosis, they will present with very non-specific symptoms. As physicians, we should take the tuberculosis as a differential diagnosis very early, not late. And then screening of adults and looking for underlying risk factors are equally important to control the tuberculous disease among the infants and the neonate. Thank you.
Thank you, Ridma.
Thank you, Ridma, for that excellent lecture. Lecture is now open for 1 or 2 quick questions.
I think somebody online wants to know if TB can be transmitted through placenta. I think you
Yes,
did
definitely.
answer
Yes,
that question
yes.
at the lecture. Any other questions from the audience?
Thank you, Ridma, for that excellent lecture. I just want to ask you regarding BCG vaccination in a patient with suspicion of family history of congenital immunodeficiency. What do you want to say?
So actually, we are on it. Really, if we have asked the house officers and the doctors in the obstetric unit, especially antenatal unit, they have to take history regarding the previous stillbirths and early neonatal deaths. Even our pediatric house officers are trained to ask that question. So when there is suspicion, we generally withhold. And if we need to screen, we do the early screening test before giving the BCG. That should be done, yes. Thank you for that question. Yeah.
Ridma, just one thing. In practice in Sri Lanka, do you come across a lot of sizable number of atypical mycobacterial kids because these immune suppressive conditions are there in congenital stuff? Do you see them or you don't?
To be honest, very rare.
We don't diagnose.
Yeah,
them
we
that
don't
often.
diagnose. I think it's with the availability of our facility, I think. Yeah. And then the yield of the samples that we get also contributing. And Dr. Shanu, do you like to add something for that? Because he's
in Colombo,
yeah, he's in Colombo, so he sees more patients than me.
Yeah, thank you. Yeah, same thing. Even some clinical suspicion of children possible the infections, but still we didn't get positive cultures, especially children with immune deficiency disorders. Our main clinical diagnosis is possible MOT-like conditions, but still we didn't get proper cultures. But yes, culture positive things are very rare.
Thank you.
Ridma, let me ask one question. Yeah. Now, we've been worrying about the non-picking up TB in children. It's been highlighted by various forums, by the WHO as well. They say we need to pick up about 6 to 8%, but we really picking up about 3 to 4%. What is your advice with regard to picking up childhood TB? Is it because these people are worrying about doing chest X's in children whenever they present with chronic cough also in this country? That practice is there, I think.
So I think it's a very interesting question. Thank you for asking that. I think there are two aspects that I see. So one thing is there's the parental aspects of looking at to get a diagnosis of a tuberculosis in their children. So there is a bit reluctancy of getting a chest X-ray, but of course I would say, like when you explain, they agree. But the only thing I think, whether we are actively thinking of the tuberculosis is the matter. That's what I feel, because as medical professionals, we have to think about the tuberculosis, otherwise it would not be diagnosed because of all the challenges that we have, like having non-specific features and especially the microbiological yield that with the samples that we get. So on the other aspect is whether we are really screening and picking up. So that aspects need to be addressed because especially the infective adult is the main source of the pediatric TB. So that unless we screen and actively picking up cases from the community who has been exposed to active TB adult, that we would not be able to catch up the missing lot.
Thank you, Ridhima, for that very illustrative talk. Do you think Gene Expert Ultra and Gene Expert in stool will make a difference to our diagnostic yield? Because WHO has recommended Gene Expert Ultra and
Yes,
because NG aspirates are cumbersome to perform in children. Is there any discussion that in LRH to have these protocols developed?
Dr. Chandra, would you like to add for that? I think the Ultra has a better outcome when you diagnose it because it catches a very little number of mycobacteria. But so far, I think we do not have.
Yeah, it's mainly the still NG aspirates. So there's mainly samples that we are taking, sir. But still, even actually we didn't inform about that use of stools. Still not practicing at LRH.
I once had discussion with Dr. Dhammika. She said that the protocols are there, but it has need to be implemented. So it would be good if we can have in stool. It will be a more accessible sample in children.
But yeah, that's of course. But usually, if we suspect TB in children, usually we admit them to hospitals, and hospitals at the inboard settings we are arranging the investigation. So because of that, gastric aspirate not a major issue. Even yes, it's a little bit of trauma to children. But the nurses and the staffs also, they are very used to these things. So because of that, I don't think that's a major issue in a practical setup. But this Ultra, that's important, sir, because we are missing some amount of children, but that's still we had only one child who had died of some unknown reasons and later came as the TB culture was positive. That one managed at a few months at MICU. Meningitis also there, but there was no initial feature suggestive of TB, but later because Gene Expert told were negative. But apart from that, so children dying with unknown disease. So if you are missing really the significant proportion of children, so then they should somehow come and they should die without a diagnosis. So during last 4 years, we had only one child, later become culture positive, and unfortunately died at MICU.
Yeah, thank you, Ridhima and Channa and all the others. So we come to the end of this session. Ridhima?
Now I cordially invite Dr. Channa De Silva, Consultant Pediatric Pulmonologist, Ridgeway Hospital, to talk on the challenges of BCG vaccination. Over to you, sir.
Good morning. I think this is the first time in this type of a national forum, separate presentations were given for BCG and related issues. So first, I would like to thank Ishan sir for his visionary thoughts and all the organizing committee and the College of Pulmonologists. So considering these important aspects, that's first thing that I would like to really appreciate. Sort of pediatricians also, I think, join online to especially to get listen to Ridhma's presentation as well. Okay, so BCG adenitis, yes, there are a lot of issues with this. Even it's a very, very safe vaccine. There are no major problems, but still we see at least one child per week having some issues related to BCG, at least at LRH. So some of these things are tricky, especially as already Dr. Vatsala raised that point. Children with immune deficiency disorders. Still we see children are dying with due to BCG vaccines. Undiagnosed children with primary immune deficiency disorder. Even it's I'll come to that later. So that type of clinical scenarios are there. Even they are very rare. So this is still actually a problem. Yeah, so BCG, so that is, as you all know, it's Bacillus, Calmette, and Gorin. So who are they? So Calmette is Albert Calmette, who is a French physician, and he's a bacteriologist, one of the inventor of this vaccine, and Calmette is the Camille Gorin is the other one. Sorry about this pronunciation, I really don't know. He's a French, he's a veterinarian, so veterinary surgeon, and he's also a bacteriologist. So work of these two, because they worked in this Pasteur Institute in France, and they use this bacteria, the Mycobacterium bovis, and they have identified with the use of special culture technique, they have identified generation to generations when they use this culture technique, the virulence of this bacteria gradually reduce. So that continue this. Over 13 years, they gradually, generation to generate, subculture these organisms into 239 times, and finally they have identified the organism is not virulent, and same time keeping its immunogenicity. So then it developed as a vaccine, and this vaccine was first used in 1921, a century ago. Still, obviously we know that BCG is not an ideal vaccine to prevent BC or the development of TB disease, but still this is the only vaccine available over the last century, whatever the despite of the development of major advances in the medicine, still to combat TB, still we have only the BCG vaccine. So still this is, even this new millennium, now we have gone again 2 decades of this new millennium, still BCG vaccine is important to prevent BC, especially the disseminated disease and the TB meningitis, so complicated TB in small children. Yeah, so what is the efficacy? As I mentioned, it is not an ideal vaccine to prevent no development of TB disease. Obviously we know, but its role preventing the disseminated disease and TB meningitis, especially small children, especially the children less than 5 years of age, that role is there. There's no controversy about that. But the prevention of pulmonary disease or adult disease or disease in older children, still it's a controversial. There are various studies, and some studies have identified the efficacy is less than 5%, or some studies just 0. For the prevention of the pulmonary TB or adult TB or the later TB disease because of this BCG vaccine, but some studies identify it may be, that's also maybe up to 80%. So there would be possible effect. Roughly we consider maybe about 30% of effect to reducing at least the severity or prevention of the development of later disease, but still, the major role of BCG vaccination is to prevent the disseminated disease and the TB meningitis in small children. That's why it is very important to give this vaccine, ideally at day 1 of age, just after birth. There are some practical issues. There might be 1 or 2 days delays, but 99% of the time, still in Sri Lanka, the BCG vaccination is given just before discharge of all the newborn babies. And there are some other studies, what is the potential role of BCG, and there would be a potential effect on other microbacteria other than the tuberculosis and leprosy also. This is one study very nicely, they have shown this potential effect, and I'm sure you have during the COVID-19 period, during the pandemic, there were some discussions about the role of BCG in preventing COVID-19 disease, which I'm not touching today. Another thing is, why this wide variation of this efficacy of BCG vaccines among people? So most possibly due to their genetic background, so and sometimes maybe the use of the different strains of this BCG, the bovine strains, and there are various studies, efficacy of BCG vaccine depend on host genetics. This was published in very recently in 2021. So that might be the reason for these variations in the response, but still it is a very important vaccine, especially to prevent deaths in small children. Yeah, so issues of BCG, there are various issues I will discuss one by one. One thing is this, the effect of BCG in TST, the MAN2, the tuberculosis sensitivity test. Yes, obviously, as we all know, there's a potential to develop post-positive results because the same, the mycobacterium group, the tuberculin test, that the 2T, the PPD we are using, it's a common to the mycobacterium group. So because of that, we cannot differentiate it from Mycobacterium bovis. from the Mycobacterium tuberculosis. So it can give rise to false positive results. But what is the actual situation? Some studies shown, it's not proven that effect of this BCG vaccination disappears about 3 to 4 years. That means after giving the vaccine. So that means the effect would be very, very minimum in giving false positive results. Other thing is, if it is just due to BCG, it's very, very unlikely to cause more than 10 millimeter reaction. That's why we keep in this 10 millimeter cutoff. We allow up to 10 millimeter to develop a reaction if it is due to BCG in immunocompetent patients, or if there's immunocompromised state, up to 5 millimeter. But if the reaction is more than that, so then it's very, very unlikely due to BCG, or very, very remote possibility. So because of that, current understanding is, so BCG vaccination was not an important cause of false positive TST. So if a MAN2 is positive, if it is more than 10 millimeter, forget about BCG, we have to think about possible TB. It may be Mycobacterium tuberculosis, so that's a different story, but the effect of BCG on giving false positive results is very, very minimal if it's a really positive test. So there are various studies regarding this, and one study is published in 2008. So they mentioned that BCG vaccine was not an important cause of false positive TST. Yeah. So BCG, invariably, the word going with the BCG is the scar. So why this scar is important? So what is the natural process? We are giving this BCG vaccine ideally the day 1 of age, or at least within first few days of life before discharge. And what will happen? So after giving this, it's an intradermal injection. So it should be definitely intradermal injection. Sometimes due to poor technique, it might be the subcutaneous. Those are the reasons sometimes develop reactions, or especially the adverse effects, abscess formation. So when they give these intradermal injections, then there's a small lump will appear at the vaccination sites within next 1.5 months of age. That means within 2 to 6 weeks of age. And this lump gradually bursts. And then there might be oozing. So this is again some concern for parents. There's some discharge, but there's no significant discharge, but there would be little oozing. So that's a very, very normal thing. No need to do anything, no need to cover it, no need to apply anything. Just can have the normal bathing. So just allow it to dry. And then within few weeks, or sometimes it will take 1 or 2 couple of months, gradually it heals. And then with this healing, the scar develops. So that's the natural process, and we can allow this process to happen up to 6 months. If the process has not happened up to 6 months, and the scar has not developed up to 6 months of age, or the 6 months after giving the vaccine, so then we can consider it as an absent scar. Yes, so the most important issue regarding this BCG vaccination is complications related to BCG vaccines. So there might be complications related to the injection site, or abscess formation, or the commonest concern about the BCG adenitis. Sometimes, this is very rare, if it is happen, it may be related to poor technique and some hygienic practices. Sometimes there can be secondary infections around the ulcer site. So this should not be happen actually, but sometimes the spread of erythema, sometimes purulent discharge, that is not due to BCG, but due to some secondary infections, maybe due to staph-like infections. So then, if that clinical picture, especially some redness around that area, like some going on cellulitis like thing, then we have to use an antibiotic like flucloxacillin, to tackle that secondary bacterial infections. But our setup, this is usually not a common occurrence. And sometimes abscess can form at the site of the BCG, the injection site, like this. This is one photograph from one of our patients. And management also the same as the management of BCG adenitis. I'll come to that later. So BCG adenitis, this is one of the major concerns, especially patients we are getting at least 1 child per week to LRH with BCG adenitis, a lot of anxiety among patients, and sometimes still we are having a lot of mismanagement. Sorry to say, but still we see a lot of mismanagement about the BCG adenitis, unnecessary burden to the child and the family. So incidence of BCG adenitis, unfortunately we don't have our own data, but various studies have identified against a spectrum of wide variation in this incidence of BCG adenitis, but usually it's less than 10%. So what is happening there? So when this, as we all know, the BCG, we are using the Mycobacterium bovis, it's a live bacillus, although it is attenuated, but sometimes this bacillus might be growing or dividing and slowly growing, and it might spread to the regional lymph nodes, and usually the axillary lymph node in the same side, the ipsilateral axillary lymph nodes, and end up as a lymph node enlargement. But sometimes even supraclavicular lymph nodes, even the cervical, this type of lymph node spread also can be happen, but that is less common. Most of the time, same side axillary lymph node enlargement is the commonest involvement of this BCG adenitis. So as this is a very slow process, it will take little time. Usually we see after about 3 to 7 months of vaccination, they gradually develop this lymph node enlargement, or just parents come with a lump in the child's axilla, sometimes accidentally detected while the baby is bathing. And sometimes when this abscess enlarge gradually and end up with abscess formation or even spontaneous rupture. So how do we manage this? First thing is, obviously, we should not just the management of this lump. We have to manage the child. We have to assess the child properly. The clinical features, if the child is clinically well, especially when assessing newborn baby, so infants, our main concerns are their general behavior, general activity, general well-being, the feeding, and their normal activities, and especially the growth. If the child is otherwise well, growth is well, feeding well, so then it's very, very unlikely this child is having some major infection is going on. So most of the time, they are limited to the site of this adenitis, and child is otherwise well, growing well, feeding well, and there's no other concerns. So child doesn't have symptoms, other symptoms like fever or any other evidence suggestive of a TB infection. So because of that, if the child is critically well, investigations are usually not required, but still our setup, sometimes we do some inflammatory markers or chest x-rays to exclude lung involvement or the chest involvement or some systemic things. Especially again, this is just to reassure parents, because very, very anxiety. They are because it's newborn baby, BCG, because BCG is a thing that we have given. So this is obviously some sort of iatrogenic complication. So just to reassure parents, sometimes we might have to do few basic investigations to exclude any sinister thing. So the other important thing is, we know this, but still we see this, especially junior surgical trainees may do this, IND. Sometimes they suspect TB, but still they do IND. Obviously, this should not be done. So as you all know, the management of abscesses and drainage, but here, this abscess is a different thing. This is a chronic inflammatory process, not as a suppurative abscess, acute inflammation. Acute inflammation, yes, the management of abscess is to drain it as soon as possible, and with a wide excision, allow it to drain. But this is completely opposite, very slow growing thing, slow chronic inflammatory process. As you all know, sometimes it might end up with a chronic discharge in sinus. It's very difficult to heal. So that's the main problem. So if you clinically suspect, especially obviously baby is well, no other symptoms, growing well, feeding well, no fever, no other clinical features, only the lump is there. Sometimes it looks like an abscess, or the suppuration would be there. So then obviously it's a clinically BCG adenitis. Don't do IND. If anyone get opinion from you, strongly advise not to do IND. Other thing is, still we see, not IND, but sometimes they do aspirations. And aspirations sent for culture and gene expert. Obviously, because bovis is growing in this active bovis is there, live bovis is there within these lymph nodes. The gene expert also will be positive, and the report of culture will come as growth of Mycobacterium tuberculosis is identified. Because our setup, we don't have facilities to differentiate the Mycobacterium bovis from the Mycobacterium tuberculosis. Both gene expert and the culture facilities, our local culture, still cannot differentiate. So obviously, the report will come as Mycobacterium tuberculosis positive. So then the next reaction is to start anti-TB drugs. So unnecessary anti-TB drugs for children or especially these infants, babies with clinically obvious BCG adenitis. So if it is BCG adenitis, don't do aspiration, don't send investigators, especially gene expert and TB cultures. Obviously this will be positive. Report will come as Mycobacterium tuberculosis. So then that's unnecessarily starting anti-TB drugs for these patients. The ideal method of this, the restriction fragment length polymerization, there's a specific PCR technique associated with Lyme probe assay. I think the machine is still available, but there are some issues with the reagents. But till, as far as I know, still we don't have facility to differentiate Mycobacterium bovis from Mycobacterium tuberculosis. So because of that, don't send these aspirations or samples for culture and gene expert if it is clinically obvious BCG adenitis. So how do we manage this? Yes. As you all know, I'm sure all we know these things, the management is conservative because it's a self-limiting thing, because the bovis is attenuated. As I shown, over 200 times they have culture, subculture, and then they have attenuated the virulence of this, the Mycobacterium bovis. So it's very, very unlikely to develop complications of the disseminated disease if the child is immunologically competent or don't have any immune deficiency disorder. So then it's a self-limiting thing. Whatever the treatments, it will take its own time to get the conditions completely settled. So we have to just explain the mother, explain the parents about the progression and how to monitor the child. Sometimes we don't know whether this child is having undiagnosed immune deficiency disorder. That type of situations, suddenly disease can get, or the conditions might get complicated. So we have to obviously follow up these patients, monitor for the progressions, and usually it will take a few months to reduce lymph node size. Even after a few months, sometimes there might be palpable lymph node, might persist for years and years. There are two types of management recommended for abscesses. Sometimes these abscesses, or when the lymph node suppurative, it might burst spontaneously. Even that burst things also spontaneously heal, but sometimes indicate to just to aspirate it without doing IND, especially from the non-dependent part, completely opposite of the usual suppurative abscesses. Abscesses IND, we are doing the independent part to allow the drainage, but here we have not to allow drainage, but if we want to reduce the size, sometimes recommend to aspirate, needle aspiration only, not an IND, to reduce the suppurative, the pus. And if this is persisting or not responding, so then the complete excision, complete surgical excision. But we have seen still early surgical excision sometimes lead into complications, wound dehiscence, and end up with, again, chronic discharge in sinuses. So what is the role of INH? Yes, so this is again a controversial issue. Still we use INH. Still there's no proven rule. We don't have randomized control trials to assess the efficacy of INH in BCG adenitis. But still sometimes we use this because there are various reasons. One thing, there might be some effect which is unlikely, but still when there's a lump is there, or sometimes children are referred to us after IND, discharge in sinus is going on. So it's very, very difficult to reassure them without any drug in our setup. So sometimes we might have to use this, that's as mentioned as a placebo, but we don't know. But according to the available literature and experience of the senior people around the world, there's no major role of INH. It's a spontaneous resolving thing. It will take time, but still some patients, in some situations, we use INH in children, especially with complicated cases, 3 to 6 month course of INH only. Other thing is they well tolerate, especially kids, they will tolerate INH, very rarely develop significant serious side effects. Yeah, so these are the usual complications, but sometimes they can have severe complications like osteomyelitis, arthritis, and sometimes subcutaneous abscesses, especially at the BCG infection, the skin involvement, or the most importantly, the disseminated BCG infection. So this doesn't happen in normal children or children with normal immunity. Sometimes disseminated BCG might be the first presentation of underlying undiagnosed immune deficiency disorder. So that is important. We have many children with disseminated BCG, but most of the time they are children with severe combined immune deficiency or some significant immune deficiency disorder. So, as already discussed this thing, so this question has raised already. Yes, this is an issue. BCG vaccination for children with possible immune deficiency disorder. So, still there's some discussion, and we actually now this discussion is going on because we have few children, maybe 20 to 25, especially Dr. Rajiv Disilla knows, and finally these children goes to him. Children with primary immune deficiency, especially severe combined immune deficiency, given BCG, unfortunately, with the history of sibling death due to severe combined immune deficiency. So, if you are working with this paternity ward, or if WhatsApp or someone get advice, if there's a history of immune deficiency disorder in a family, especially sibling death due to a severe combined immune deficiency or some sort of severe immune deficiency or undiagnosed pneumonia or some severe condition, so best approach is to delay giving the BCG vaccines till we exclude the possible primary immune deficiency disorder, because this is live vaccines. Once we give this, so it's very difficult to control if there is a severe immune deficiency disorder. And we have a few children actually not have had, because they have died, even they undergone this bone marrow transplant, because that is available Sri Lanka, bone marrow transplantation. That's also would not be possible if the baby developed disseminated BCG infection. So it's very, very difficult to treat. So this is very, very important issue I want to stress at this point. So if there's a family history of immune deficiency or sibling death, so we have to, right. And the final thing is absent BCG scar. This is another thing. So scar indicate developing immunity, obviously. So we can wait up to 6 months. Then usually it's sometimes this scar might fade away. And if the mother is sure there's no scar, if the baby is less than 5 years, just straight away give the vaccine, revaccinate without doing MAN2. No need to give MAN2, no do the MAN2, because it's obvious, then no need to do MAN2. If the child is more than 5 years, no need to give BCG, because as I mentioned earlier, the primary importance or the primary function of this BCG vaccination is to prevent the disseminated disease and the TB meningitis in small children, especially less than 5 years of age. So then no need to give it children over 5 years of age, because there's no major protections against the pulmonary TB or adult TB. So in summary, BCG is the only available vaccine against TB since its introduction over a century ago. Still have important role, very safe for large majorities. Large majority, this is a very, very, very safe vaccine, and substantial proportions of complications. Even though a small proportion develop complications, those also self-limiting, but it's especially important to avoid BCG scar if there's a history of severe immunodeficiency in the family. Thank you.
Thank you, Channa. We have one question I think you have answered again. What's the significance of not having the BCG scar? I think you...
Yeah, same thing, yes. So there's no significance if the child is over 5 years of age, because he has already passed that the stage which has a high risk. Sometimes this is common thing is children coming from abroad. Sometimes they born at Italy or some other countries, lived there. Obviously, no BCG is given. Once they come to Sri Lanka, so there's some concerns whether they need BCG. But if they are already over 5 years of age, no need to give it. Less than 5 years, if there's obviously BCG scars absent or not given yet, straight away we can give. No need to do MAN2.
Thank you. Do you have any other questions from the house?
Thank you, Channa, for the excellent talk. And you just answered partly the last bit, people returning from Italy and various countries. And they say that they want to come back, they have not been vaccinated. And some of them, they are coming here to raise their children here. And some of them are going back to the Western countries. So in that case, will you need the BCG again? They will be coming here and there and going.
Yeah, again, same, sir. The same, the main purpose of giving this to prevent development of disseminated disease and the TB meningitis, the effect of reducing the adult disease or the pulmonary disease is very, very minimum. So because of that, usually there's no indication to revaccinate if they are older over the 5 years. Even if they going back anyway, their risk is very, very minimum because most of these Western countries, the prevalence of TB is low, no? So there's no real indication to give it. We can just explain the requirement, and if they really want or due to some other reasons, we don't know, but we may revaccinate, but otherwise usually it's not indicated.
So thank you, Channa, for that very interesting lecture. Thank you.
You will hear the World TB Day song. It was produced exactly a year ago during the peak of economic crisis where we had longer power cuts and fuel queues. So Sri Lankan College of Pulmonologists used modern technology to reach the public to increase the awareness of tuberculosis. This beautiful song is sung by 4 consultant respiratory physicians, Dr. Shant Pereira, Dr. Yamuna Rajapaksha, Dr. Niranjan Disanayaka, and Dr. Chanaka Ratnayaka. It's written by Dr. Sindhu Senirathna, Registrar in Family Medicine, who did the respiratory short appointment at that time. It's tuned by Mr. Jeevan Roksami. Except for the 2 nursing officers, rest of the cast in the visual is performed by the doctors. And let me briefly outline the storyline of the beautiful visual, which gives a powerful message. There are 2 lovers where the girl is having chronic cough and she's taken to Velisara Chest Hospital by her fiancé for further investigations. And then there she's diagnosed to have tuberculosis. Having confidence in the TB treatment, the boy marries the girl and they get treatment completed, and after that they are leading a happy life with 2 children.
Susuman pawa unusum bela wadalaya kalba Sangadi ki jaadu
Laya parna roduk nisa sita mangulavi asarana bunado
කඳුළු රහසේ ඉඳගන්න පෙර පුරුදු දිවියම
නිසි කලට පිළියම් ලබන්නට
සුවය පවනෙමු නුඹේ අතුලේ කංගල් වෙලෙත් ඉරවුනින්දදෝ
Good morning. I thank the President and his Council for asking me to speak on this occasion on an important topic. So CNS-TB has always been challenging. All cases of CNS-TB, I presume, are difficult. This is the outline of my talk. Okay. Yeah. So the epidemiology, clinical cases, diagnosis, and pharmacological management complications, clinical challenges, and future directions is what I hope to speak on. A little bit facts on TB. CNS TB accounts for 1% of all forms of TB and 6% of extrapulmonary TB. In miliary TB, 20% have CNS involvement. CNS TB includes TB meningitis, tuberculomas, and spinal arachnoiditis. I would not be speaking on spinal arachnoiditis, but I'll speak on TB meningitis and tuberculomas. TB meningitis with or without tuberculomas accounts for about 75% of CNS TB. Tuberculomas alone account for the rest of the 25%. TB is a medical emergency. TB meningitis is a medical emergency and carries a mortality rate of around 15 to 40%, depending on the stage in which it's diagnosed. 25% of patients with TB meningitis will end up with permanent neurological deficits. A little bit on the pathophysiology. Its primary pulmonary focus may disseminate through the bloodstream and lymphatics and cause seeding in the meninges, ependyma, ventricles, and brain parenchyma itself. These foci may coalesce, proliferate, caseate, and then break down into the arachnoid space. They also causes vasculitis, and they may cause thrombosis, thrombogenicity, and obstruction to the CSF flow, communicating and non-communicating hydrocephalus, cranial nerve damage, and a basal meningitis. So this is as I said, TB meningitis goes through phases. The early phase has a prodrome with non-specific symptoms of about 1 to 3 weeks duration, with malaise, lassitude, fever. It's followed by a meningitic phase where patients may have headache, photophobia, vomiting, neck stiffness, cranial nerve involvement, and also various neurological deficits. Then there's an accelerated phase in which patients become comatose, stupor, and may end up in death if untreated in 5 to 8 weeks. So this is the first case of mine. It's a 28-year-old female who had a history and a similar prodrome. There was, with worsening headaches, a history of 1 month's duration, worsening headache with altered level of consciousness. There were no focal neurological deficits or cranial nerve palsies. So that's the CSF of this patient. On the patient CSF is there on your left side, and the CSF changes in TB meningitis on the opposite side. So in most patients, the CSF is clear, but it may have a coagulum. Opening pressures are high, and opening pressures, I think, are important to note and document. The total WBC counts are high. Initially, it can be a neutrophil leukocytosis, but later on, it becomes predominantly lymphocytics. Protein is high, and it can be very high if there is obstruction to CSF flow. So in our patient, the patient had a very high protein content. Sugars were very low, less than 15% of random blood sugar done at the same time. So it's important to send the random blood sugar at the same time, because a 50% reduction in your CSF sugar is a good indicator, a sensitive indicator combined with your clinical and other imaging in the diagnosis of CNS TB. So our patient had a predominant lymphocytosis. AFP direct smears were negative. Adenosine deaminase, not something that we do frequently. I'll subsequently talk about this, was 10. Cytology showed no atypical cells. Gene expert was negative in our patient. In immunocompromised patients, CSF may be acellular. So CSF bacteriology predominantly depends on the volume and the number of samples sent. So the available literature suggests that at least 6 ml of CSF should be sent for microbiology exclusively. The yield has been better if you do centrifugation at 300 revolutions for 20 minutes and then examine your CSF. Larger volumes have been associated with better yields, and in fact there are some studies where you prepare the CSF smear in this drop, like a drop when you are doing the sputum smears, that yield can be high. But in practice, we are never able to achieve these volumes of CSF, and doing repeated samples, maybe doing 3 repeated samples, will increase your yield, both of smear, culture, and also your PCRs and other assays. And they say that you can remove 10 to 12 ml of CSF safely, but in practice, we hardly ever see this kind of volume removed. But I think centrifugation is an important step in enhancing your bacteriological yield. So nucleic acid amplification test forms a cornerstone of our diagnostic modalities along with the imaging and your clinical things. But you shouldn't be guided by this. If the clinical indicators and your imaging suggest CNS-TB, you shouldn't wait for microbiological confirmation in form of GeneXpert Ultra or GeneXpert. So a Cochrane review of these studies have shown a sensitivity of 89% and a specificity of 91 in 6 studies done on GeneXpert Ultra. Ultra, we have had problems sometimes because Ultra has a tendency to give looks at more primers, has a tendency to give a false positive rifampicin resistance. So GeneXpert, again 30 studies have shown a lower sensitivity but a more specificity. So as I said before, you shouldn't rely on your microbiological confirmation when it comes to TB meningitis because it carries a high morbidity and mortality. So the culture modalities are retrospective. As you know, even the liquid cultures will take 2 weeks to come. The solid culture, the LJ media cultures, 5 to 8 weeks. 6 to 8 weeks. So the diagnosis will be retrospective. But it's also always important to send cultures because when you are encountered with a difficult to treat case, you may, though the sensitivity is 30%, you may be able to retrospectively see whether your culture is positive and whether there is any evidence of antimicrobial resistance. So it's important to send cultures in all patients because it will have a retrospective diagnostic utility. Adenosine deaminase has been mainly validated in body fluids, mainly in the pleura, because pleura has a gold standard comparator where we can do histology and culture of pleural tissue and compare with ADA. We use a cutoff of 40. In CSF, there are some studies that have shown that adenosine deaminase with a cutoff value of 10 has been useful to identify useful supportive evidence of CNS-TB. But unlike in pleural fluid, in the CSF, 40% of lymphocytes are destroyed within 1 hour. So your number of lymphocytes are very less in the CSF unless it's when in vitro, unless it's processed very fast. And again, it does not help you to discriminate between pyogenic meningitis and other forms of meningitis like cryptococcal meningitis, brucellosis, and lymphoma. So in terms of diagnostic utility, it does not have a big role to play. A cell wall component called lipoarabinomannan has recently been approved by WHO in the diagnosis of patients with HIV and tuberculosis. This is a cell wall component which can be detected in urine. It's a simple test which you can perform and does not require the equipment and the technical expertise of Ultra or GeneXpert. It has been shown in some studies in CSF to have an equal sensitivity as GeneXpert Ultra, around 70% sensitivity. So this may be a test that we would look for in the future. Again, interferon gamma assays have been studied in the CSF, but the diagnostic utility of that has been, contribution to the diagnosis has not had a significant impact in its contribution to the diagnosis. CSF chloride was something that we were looking at, whether it would help us to discriminate TB meningitis from other form of meningitis. It has been said that a chloride level more than 110 almost always excludes CNS-TB. But of course, chlorides can be high in many other conditions, including pyogenic chlorides can be low in many other conditions, including pyogenic meningitis, brucellosis, and things. So a discriminating value would be very low. It is very important to do chest radiographs in these patients because on doing chest radiographs, in a patient with suspected CNS-TB, you may see miliary mottling and miliary changes on the chest radiograph. And you may also see evidence of other radiological changes suggestive of pulmonary TB. CT brain is useful, and the features that you look for, contrast enhancing basal exudates, infarcts, especially in the basal ganglia and thalamic regions, and tuberculomas. So these are very sensitive indices in diagnosing CNS TB. So our patient had an MRI scan. She had multiple infarcts in the thalamopontine regions. She had appearance of acute, she had early onset hydrocephalus, and this along with the CSF findings suggested favored a diagnosis of TB meningitis. MRI brain is superior to CT because it helps to image us the infratentorial regions, especially the peduncles and things, in which you would get more detailed information when it comes to a diagnosis of TB. But you will have a wide differential diagnosis, including cryptococcal meningitis, toxoplasmosis, neurosarcoidosis, secondaries, and lymphomas. So again, the tuberculomas are interesting because tuberculomas in active disease, tuberculomas appearing during treatment, tuberculomas along with CNS TB also provides useful information. Tuberculomas may be of various stages, organized fibrotic tuberculoma, more cellular tuberculoma with a necrotic caseous center in which mycobacteria may be still replicate, and the regions these are located, and the chronological order they may appear are also useful. MR spectroscopy, on occasion we have used when there are single tuberculomas to differentiate from malignancy, where MR spectroscopy may show a carbohydrate peak in these patients. So MAN2 test, we have heard about the MAN2 test. It is only supportive, and it can be negative in patients with tuberculosis, especially with CNS TB, especially with disseminated miliary forms of tuberculosis. A newly developed antigen test, TB antigen test by the Serum Institute of India, WHO has introduced this as a form of diagnosis of latent TB, and it's supposed to have equal sensitivity to IGRA when diagnosing latent TB. So this may emerge as a less low-cost test that will be available in the future through the National TB Control Program. So various scoring systems have been proposed in the diagnosis of TB. So these have some value, but mostly in follow-up and research series. Your clinical, because of the high mortality associated with TB, your clinical judgment and your imaging with your CSF should play a more important role. In our patient had a transaminitis, liver enzymes more than 100, even before the anti-TB was started. So we have noted that some of these patients have disseminated TB with miliary involvement, liver involvement. So this is another challenge that we have to do. So the patient was started on IV dexamethasone, deranged liver function was there, disseminated TB was suspected, a transaminitis was suspected, and then we are faced with situations when deciding on an anti-TB regime. So INH has good CNS penetration, crosses the CSF barrier well, but rifampicin in the doses that we prescribe, the equivalent to have 30% of the equivalent serum dose, you have to have higher doses of rifampicin. So rifampicin, when we use in combination, also in fixed dose formulation, we are not sure how effective rifampicin in these fixed dose formulations is when crossing the CSF barrier, blood CSF barrier. Pyrazinamide has a good role, is a useful CSF penetrant and has good activity in caseous acidic media, like in the center of tuberculomas. Our fourth drug, then we have to decide whether it's ethambutol or streptomycin. WHO tends to move away from streptomycin now, and we use ethambutol in these patients as a fourth drug. But now when we are encountering a situation like this, where the transaminases are high before starting treatment, what are we going to do? We would try a bridging regime, but then in our bridging regime, we are using ofloxacillin sometimes, which you shouldn't be using, but levofloxacillin, streptomycin, and ethambutol. As already said, ethambutol and streptomycin are poor CSF penetrants, so we are exposing a patient to a single drug, levofloxacillin, and sometimes this bridging time to get the liver enzymes down and to reintroduce the anti-TB drugs, it may take more than 2 weeks. So you saw the phases that the patient goes through, the high mortality associated with, and the arachnoiditis and the other basal meningitis infarct that the patient is likely to develop. So in such situations, are we okay to have a patient on a weaker regime of streptomycin, ethambutol, and levofloxacillin? or should we think of alternatives? There are alternatives which has been suggested like ethanamide and linezolid during this bridging time, which have good CSF penetrant, but of course these are reserved drugs in treating drug-resistant TB. So now we are developing the guideline on extrapulmonary TB. So we are having discussions on this to look at these alternatives, because I think time is vital in these patients, because we see a lot of difficult to treat resistant cases, and I think the initial bridging treatment, whether it's before treatment or whether the patient subsequently develops a transaminitis while on anti-TB, should be carefully thought of. So fluoroquinolones has good CSF penetration, but its role in reducing mortality is not well documented. So we use steroids as adjunct drugs during the initial phase for about 2 months, 4 to 8 weeks, dexamethasone or oral prednisolone. This is because of basal meningitis, endarterectomy, tuberculosis, and paradoxical reactions that have been associated with TB. So the role of repeat LP is also important. CSF changes, mainly after starting treatment, the sugar normalizes, the protein may reduce, the cell count may improve, the PCR may remain positive due to dead bacilli even, but it will take a little time to normalize, but the glucose is a useful guide. So paradoxical reactions have been a real challenge in managing patients. We have seen many patients with resistant tuberculosis appearing during treatment, optichiasmal region tuberculosis, arachnoiditis, and which have been a real challenge for the neurology teams and us to manage these patients. So the risk factors are female gender, HIV status, shorter duration of illness. Usually they can occur 10 days to 4 weeks, within 10 days to 4 weeks, but we have seen presumed paradoxical reactions occurring quite late in the disease, several months after treatment also. So it's, as we know, a hypersensitivity reaction. 1/3 of the patients develop tuberculosis, and as I said, can occur later in the disease. Having a lymphopenia at the outset may predispose a patient towards developing paradoxical reaction, and the CSF shows an initial neutrophil shift in these patients. So we have tried to look whether the CSF sugar is a useful indicator in these patients to see whether we presume if there's ongoing disease, mycobacteria in the CSF, the sugar may be low. Should sugar also be a useful indicator? For the series of patients that we were able to review, and Dr. Madhushankar, my SR, has helped me in this, we haven't really been able to find any conclusive evidence to suggest that CSF sugar is a useful indicator, but I don't think they have looked at it also. No? They haven't analyzed that data also. So maybe we should do some work in this area to see whether this is a useful indicator to differentiate ongoing disease from a paradoxical reaction. So when we are confronted with a patient with ongoing disease, we have to see whether the patient has been compliant with medication, whether there is drug resistance evolving, whether the drugs, as I said before, the fixed dose formulations, we tend to use the individual drugs more now than fixed dose combinations in CNS TB patients, and whether we should go for a higher dose of rifampicin, 600 milligrams. These are the things that we are discussing when we develop the new guidelines. So from case series available, paradoxical reactions are a real challenge as I said. So they may even develop months later. Tuberculosis may take 3 to 6 months to reduce. Optochiasmatic arachnoiditis may not show radiological resolution even after being treated for a long time. So the duration of paradoxical reactions is also very subjective and variable, because most of these patients have been on steroids, and when the steroids are tailed off, they recur. There are some series which have used steroids for prolonged periods, as long as 12 to 18 months even. Right. So again, persistent of tuberculosis, whether this is an immune-mediated reaction, whether this is a disease process itself, is difficult to differentiate and is quite challenging for us to manage. So other immune-modulating drugs like thalidomide, infliximab, lenalidomide have been used in this patient. There are 1 or 2 patients whom we have, after having multi discussions with the neurologist and other clinicians who are managing patients, whom we have excluded ongoing diseases and started on thalidomide. But it has been true, the response in the 2 or 3 patients that we have started on thalidomide have been variable. Some have showed some resolution, but recurrence, and they have needed steroids to be given. Infliximab also we used in one patient, Professor Chang's patient. Still, I think about maybe 2 months or 3 months of infliximab. Too early to say whether the patient has shown good response. So there are some indications for surgery, like hydrocephalus is the most common indications. Sometimes these tuberculomas may coalesce and form abscess and cause behave like space-occupying lesions. In such instances, there may be a place for surgery. And of course, as a diagnostic utility to stereotactic biopsies, there are a couple of cases that we have done with the neurosurgical advice. So these are some resistant cases which I would like to share with you. This is a 22-year-old university student who came with headache, bifrontal and occipital, diagnosis of CNS TB, gene expert negative, anti-TB started, then went on to develop communicating hydrocephalus, cerebral edema, and those are the serial CSF, which shows an improvement in sugar. But the patient had hydrocephalus, and then optic-asthmatic arachnoiditis, multiple infarcts and vasculitis, and also went on to develop panhypopituitarism. This is another patient who, after 2 years of treatment, again had spinal lesions suggestive of tuberculoma with some surrounding edema, even after 2 years of treatment. So do these tuberculomas completely go away after treatment? Are we justified in continuing treatment for long periods of time? So these cases have been a real challenge. Again, a patient who was diagnosed as Kikuchi's disease, was on steroids and methotrexate, continued to have ongoing fever, sputum positive, microbacteriologically confirmed TB, but the patient went on to have disseminated TB, pulmonary involvement, gene expert positivity, CNS involvement, and still after prolonged periods of treatment, still has what looks like tuberculomas and arachnoiditis involving the optic-asthmal regions. So CNS TB has been a real diagnostic challenge, requires input from many clinicians, neurologists, and the radiologist. It has the newer test, and we need new bacteriological tests, more sensitive indicators, gene expert and gene expert ultra, maybe TB-LAM or lipoalbumin Menon assay may have a role to play. Neuroimaging plays a key role, and now we have a consultant who is board certified neuroradiologist, so their inputs are vital in managing these patients. HIV co-infection will also be a challenge in the future. We need to have a clear-cut idea of how to diagnose paradoxical reaction and how we are going to manage this patient and how we should differentiate paradoxical reactions from ongoing disease processes. So far, we haven't had MDR-TB patients with CNS involvement. Maybe I can remember one patient, but still we haven't had patients with CNS TB who have MDR-TB. So how long should we give steroids for paradoxical reactions? Are there any biomarkers for paradoxical reactions, CSF and other? What is the role of thalidomide, infliximab, and other immune-modulating TNF-alpha drugs? When should we start this? Most of the series that we have seen in South Africa, they have started thalidomide fairly early in the disease, but whereas we are starting them as a salvage when we have encountered with resistant tuberculomas and we have ongoing symptoms, including radiological evidence, MRI evidence of edema and disease activity. Then only we have started them, or we are thinking of starting them on drugs like thalidomide and infliximab. So whether these should be started early, areas that we should be looking at. And optic-asthmal arachnoiditis, as Madhushanka said, that it never disappears, right? You said the imaging may not disappear at all. So whether we are justified in persisting with this medication based on radiology alone, sometimes the CSF is normal, acellular, protein is normal, is unanswered questions. So in conclusion, I wish to thank the neurology SRs who shared their cases with me, who presented these at MDT discussions, my own SRs, Madhushankar, Manisha, Ravini, Ruini, and Ravini is past SR, right? Lakmini and our team. I'm sleepy, I'm jet lagged. I got up, I came at 2 o'clock in the morning. And Ruanti, my co-consultant, for helping in these cases and sharing their knowledge and expertise. Thank you.
Informative and excellent lecture, sir, especially within few hours after arrival from overseas.
I should have had another vodka. I think.
We can arrange later on. Lecture is now open for discussion.
Thank you very much, sir, for that excellent talk. And touching on that complicated area when it comes for TB management. Now, you said that you said the diagnosis is sometimes very challenging, and we are compelled to start on ATT on many occasions. And first lumbar puncture, most of the time in those cases are inconclusive. And at which point, because you mentioned about second lumbar puncture or even third lumbar puncture in those cases, at which point you would think and suggest to go ahead with the second lumbar puncture, and on what basis you take the next step on that lumbar puncture findings?
Yeah, thank you, Afal, for that excellent question and that very practical question. The key thing has been the CSF volume. The CSF volume, which they are saying at least 6 ml for microbiology alone. So take that 6 ml, centrifuge it at 3,000 revolutions for 20 minutes, and then get that and do the microbiology in that. And to supernatant, you can set for bacteriology. So the studies that they have done 3 consecutive LPs. 3 consecutive LPs like we are doing sputum. So these, of course, was more in relation to acid-fast smears and cultures. So and the same applies for Gene Expert and Gene Expert Ultra as well. So maybe a second LP very soon before you start the anti-TB or concomitantly, within a day or two might increase your yield. And we have to discuss with the microbiologists about centrifugation. I think at Valisara they do, no? Dr. Chinta was saying that they routinely do centrifuge specimens when they get CSF, but I don't know whether we had to find out at NHSL, no? Whether they routinely practice centrifuge specimens. Well, the real challenge has been this tuberculomas. Tuberculomas sometimes paradoxical reactions. I don't know whether they can, of course, say so late in disease. They say for 10 days to 4 weeks, but really later on disease. So we don't know whether there are mycobacteria in that caseous material, and they are slowly releasing cell wall material into the CSF, no, giving rise to this intense immune reaction. So that has been a real nightmare.
Any other questions from the house? Yeah, I guess Dr. Amit Fernand is always available at his clinic. If you have any questions, of course, we call.
Yeah, I think we meet the research frequently and they come for appointments. And we must be thankful for the excellent support and discussion by the neurologists, Dr. Bimsara, Arjuna, Gamini, and Professor Chang when managing these patients, right? So they have been a great help. And I think one neurologist, SR is doing a study also on this, no? It's following these patients up. As Madhushankar said, we should look for homegrown solutions. We are people who have these large volumes of patients, and we are looking for literature in other countries, in low prevalence, other countries where they may not encounter this number of CNS TB patients.
Right.
Okay. Thank you.
Thank you, sir. Thank you.
Now I invite Dr. Bandaguna Sena, Senior Consultant Respiratory Physician at National Hospital for Respiratory Diseases, to talk on delivering of comprehensive care of multi-drug resistant tuberculosis patient. Over to you, sir.
Thank you. Thank you. I first thank the College of Pulmonologists for giving me this opportunity to talk on this topic. Talking on comprehensive care of MDR-TB is a bit of a very, with so many facets and extensive discussion. So I thought I will limit my lecture to 20 minutes by talking on essential things that you might encounter in managing MDR-TB patients with new guidelines. Okay, right. MDR-TB cases, sometime back in early 2012, 2013, we were having about few patients, about 5-6 patients per year. Now it has gone up to 20 cases. And our duration of treatment is also more or less around 1 to 1.5 years. Therefore, every year we have about 20-25 patients on treatment, while we are detecting new cases, about 20 or 15 to 20 cases a year. Do it this way, right? Right, thank you. Now, when we encounter a TB patient, we consider certain high-risk groups where we will try to do initial gene expert and expert MTB RIF and also cultures if we consider the patient is a high-risk patient to have MDR-TB. Like symptomatic context of MDR-TB patient, currently we have a patient in the ward where the patient's father was a MDR-TB patient, but twice the patient was given courses of standard treatment, and when the patient has failed to show a response to second course of anti-TB drugs, only they started exploring whether it's a MDR-TB patient. Then only they realized it's a MDR-TB case. So also if the patients are sputum positive of 2nd month and 5 months, we will consider at 5 months, really we call it treatment failure, and then we will investigate this patient for drug resistance. Other than that, we have HIV patients, prisoners, drug addicts, returnees from abroad, and healthcare workers, and patients treated outside national TB program. If these patients come as TB cases, one would consider MDR-TB and do the necessary investigation right at the beginning. If you consider drugs, there are several groups of drugs. The standard drugs are isoniazid, rifampicin, ethambutol, and pyrazinamide. And there are other groups of drugs which are used for as second-line drugs when the standard regime is failing. There we have the diroquinone is a forerunner, where we have bedaquiline, one of the effective bactericidal drugs that we use against MDR-TB patients. And in this list, this is a kind of an old slide where the capreomycin is now gone out of practice. And also, yeah, that's it. And also out of the aminoglycoside, nowadays we are not using kanamycin. We are concentrating on amikacin and streptomycin only. And if you consider drug resistance, there are several types of resistance. One is monoresistance, where your organism is resistant to only one drug. Polyresistance is you have resistance against several drugs, but not INH and rifampicin together. If you have INH rifampicin resistance, that is MDR-TB. And we have the other group where you have MDR-TB plus quinolone resistance. We call it presumptive extensive drug resistance. And then if the patient to be considered as a confirmed case of XDR-TB, you need INH and rifampicin resistance plus quinolone resistance with resistance against another group A second-line drug. I will tell you what these group A second-line drugs as I go on. If you have RR, if you say RR, that means rifampicin resistance alone. When you are diagnosing, we have the molecular methods which are useful to diagnose early, the disease early, get the drug resistance patterns early. Expert MTB RIF is done in National TB Reference Laboratory and 14 other centers. And that is, even for sputum negative case, it is about 72% sensitive. And we have line probe assay, which can detect isoniazid and rifampicin resistance both. Whereas expert MTB RIF will detect only rifampicin resistance. line probe assay can be done only in sputum positive cases. Therefore, if the patient is want to do a line probe assay, generally what is done is the sputum is put into liquid culture, and from the culture isolates, the line probe assay is done. And the drug sensitivity testing for these things are done in the liquid culture medium only at the National TB Reference Laboratory. And if the patient is sputum positive at 5 months, we can do expert MTB RIF. The sensitivity is like you need about 130 colony forming units per microliter, and then you can do first line probe assay from the gene expert MTB RIF. You can detect rifampicin resistance, and then you can subject the patient's sputum to line probe assay to get whether the patient is having isoniazid resistance as well. Expert MTB RIF Ultra can detect, it has a higher sensitivity, as earlier mentioned in this forum, that they are less specific because even a small particle can give an expert MTB RIF Ultra positive. You need only about 16 colony forming units per, I think it's microliter. And then expert, now we have expert MTB RIF that is detecting only rifampicin resistance, but now the new kits have come where you have expert MTB XDR, where you can detect drug resistance against isoniazid, amikacin, ethionamide, and fluoroquinolone. And second line line probe assay is now, I think, already established, but still to be done against fluoroquinolones and amikacin. Currently, currently LPA is done only for INH and rifampicin, but soon they will start doing fluoroquinolone and amikacin sensitivity testing with line probe assay. If you see a culture positivity for isoniazid and rifampicin, that is a confirmed MDR case. And if you see non-conversion or reversion, the patients are not converting on treatment, or if they revert after some time of being sputum negative, then patient again convert to sputum positivity. That is an indication of drug resistance. And now, the next sentence is regarding drug MDR TB patients. At the end of intensive phase, if the patients are, you have to have 4 consecutive cultures to be negative for you to call it a cure. But halfway, if they become positive in MDR TB patients, you would consider it as a presumptive XDR case where you will have a doubt whether the patient is having quinolone resistance and other resistance. Now, as I told you earlier, if there's quinolone resistance confirmed, that is a presumptive XDR case, and if it turned out to be resistant against another group A drug, then the patient is considered XDR TB. I'll tell you what these group A drugs as I go on. So expert MTB RIF will take about 2 hours, and it needs minimum manpower. And if you have rifampicin resistance in a patient, RR positive means it's a strong proxy to MDR TB, because almost all the patients who are rifampicin resistant if you test their INH resistance also, that is the common understanding. And if the patient later on turned out to be INH sensitive, then you label that patient as RR rather than MDR. So the expert MTB RIF is done also in presumptive MDR cases, as I told you, and then pediatric samples, CSF pus, where you tend to have minimum cells. Those samples are subjected to MTB RIF. Now, pleural fluid is still not validated. There's a small doubt whether pleural fluid are really useful to do expert MTB reef. Currently, we are not doing, but world literature says there's a place for doing expert MTB reef in pleural fluid as well. Turnover time for each test. Turnover time is after dispatching your sputum or whatever the body fluid sample from the ward until you receive the results. That is turnover time. Acid-fast bacilli, for acid-fast bacilli Direxmias, it will take about 48 hours, and expert also 48 hours. Line probe bacilli about 3 to 5 days, and liquid cultures about 3 weeks. Liquid Direxmia again another 2 weeks. And solid culture about 2 to 6 weeks, and solid culture Direxmia, the drug sensitivity testing is about 7 weeks. Now, the expert MTB machine will detect certain gene proteins in the mycobacterium. The rifampicin resistant gene is RPOB, which is detected by the expert MTB reef machine. And there are other gene mutations, like CAT-G mutation with regard to isoniazid and INHA. And also, INHA will indicate ethanamide resistance. And also, quinolone resistance is detected by gyrase A and gyrase B. Small thing about CAT-G mutation. Now, some of the regimes that we are using for MDR-TB will have high-dose isoniazid, the shorter regime. But if the patient has CAT-G mutation right at the beginning, then that high-dose isoniazid regime is not used, because that means the organism is totally resistant to even high dose of isoniazid. Then you have to have an alternative regime, non-isoniazid regime. Now, the shorter regime that I've been talking about, we have 2 regimes generally for TB treatment of MDR-TB, shorter regime and longer regime. Both have shown equal efficacy by a study done in Europe called STREAM trial. Because shorter regime is short, the case holding is better and it's less costly. And side effects are more or less similar. But there's a small concern about higher relapse rates after a shorter regime. But remember, earlier the shorter regime came with aminoglycoside in it as one of the drugs. But now aminoglycoside has been taken away, and instead of aminoglycoside, we are using bedaquiline. Now this problem of whether they have higher relapse compared to longer regime is still questionable. Maybe they are as effective. The shorter regime is simple. You have only 11 months of treatment. Sometimes this can be shortened to 9 months if the patient responds very quickly. Where in the first 6 months you are giving 6 drugs, bedaquiline and high-dose isoniazid, along with levofloxacin, clofazimine, pyrazinamide, ethambutol. In the second 5 months, you drop bedaquiline and isoniazid, and then you continue with the other 4 drugs. One point about short regime is you cannot, if you find side effects against one of these drugs, say bedaquiline-induced cardiotoxicity, there you can't add another drug and have a modified shorter regime. Generally, shorter regime is one. Studies were done, efficacy is proven, and if you are using, you have to give in toto. You can't compromise this. If you have to compromise shorter regime, recommendation is go back to the longer regime and have your drug selected from the normal general group of second-line drugs. I'll come to that. Now, if you are using shorter regime, one of the key drugs in this regime is levofloxacin or quinolone. Now, you have to have whether, you have to know before starting shorter regime whether the patient is quinolone sensitive. Currently, we don't have still the facilities to do quinolone resistance. With new XDR kits, probably we may be able to do. Therefore, if we are starting short regime, we are kind of starting blindly, knowing that our quinolone resistance is low in this country. But still, if the patient has CAT-G mutation, definitely you can't use short regime. But INH mutation, still you can use high-dose isoniazid. Currently, we don't have bedaquiline and clofazimine sensitivity testing, but if you have that, that's desirable to have bedaquiline and clofazimine sensitivity testing before starting short regime. These are the drugs that we use, Group A, Group B, Group C, and Group C. Now, Group A drugs are quinolones, bedaquiline, and dinazolid. All three drugs are used in your longer regime. Plus, one Group B drug, that is clofazimine. In case you cannot use one of these drugs, 3 drugs from A and 1 clofazimine from B, you might go for cycloserine. Still, you have to compromise more than one drug, then you may have to select a drug from Group C. But you have to have at least 4 bactericidal effective drugs against your treatment in your treatment regime. Now we don't go for injectable unless it's absolutely necessary. If you can find oral regime, oral drugs, you will go for fully oral regimes. But if you are using injectables, it is desirable that namely amikacin and streptomycin is desirable to have confirmation of sensitivity. Now, if you have any doubt, thinking that this regime is showing drug reactions or you are in doubt about the efficacy of these drugs, you can switch. Unlike your rigid regimes that you use in standard treatment of category 1 or standard sensitive treating of sensitive organisms or shorter regime. Here, there's room for alternative choices and adjust the most suitable regime for the patient. Maybe you need little experience in doing this job, but the recommendation is don't go on with so much side effects and risk of giving compromised regimes. Change the drugs quickly and have an effective regime for the patient. This is our current longer regime, where you use 4 drugs plus pyrazinamide throughout. Bedaquiline is given for only 6 months because it has toxic side effects like cardiac arrhythmias with QT prolongation. Again, it's ideal if you can have quinolone sensitivity testing done, and if the patient should be not eligible for shorter regime, because short regime is having good efficacy, same side effects, and good case holding. Therefore, short regimen is recommended by the WHO and other donor agencies who are providing drugs to us free of charge. And then, so therefore, if the patient has a list of criteria where patient may not become eligible for short regime, like severe liver diseases and cardiac diseases, pregnancy, and with small children. That type of situation, and also TB meningitis, where you have to give a longer duration of treatment, where your short regime will stop at 11 months maximum. Therefore, in that type of situation, a longer regime is recommended. And also, if you have bilateral cavitating extensive lung disease, where you don't use short regime, maybe they think that this patient have disseminated TB when you have extensive lung disease. That is an assumption. That is why the short regime is not recommended for patients having extensive lung disease. If you cannot use bedaquiline, you can use, instead of bedaquiline, cycloserine from group B. And if both cannot be used, then you go for amikacin or injectables. If the patient has bedaquiline-induced cardiac toxicity, the delaminid, which is group C drug, cannot be used because both have similar problems with QT prolongation and cardiac toxicity. If the patient has a presumptive XDR, then you will do the bedaquiline, quinolone resistance testing by MTB, expert MTB XDR. Your treatment is, again, more or less 18 months, where you don't use quinolones, you are using other drugs. But our problem is if you come across a patient who fail your MDR-TB treatment, we are in deep trouble because bedaquiline already used, clofazimine, linezolid, all the drugs already used, and the patient is failing to respond to standard longer regime. Currently, we have one patient like that. It's a nightmare. So depending on antibiotic sensitivity testing done in reference laboratories, you might decide on regime. There's another regime called BPAL regime where you will use bedaquiline, pretamimide, and linezolid. If you detect quinolone resistance right at the beginning, so if you do MTB RIF XDR, and then if you detect there's quinolone resistance, the recommendation is BPAL regime, which is given for 9 months, which will have bedaquiline, pretamimide, and linezolid, but no quinolone in this regime, given for 9 months. Side effects, of course, no one can remember all these side effects. We have all reference books regarding these side effects. So whenever you come across psychotic symptoms, seizures, skin reactions, hearing loss, you may refer these notes and find out. But your special attention should be there with regarding prolonged QT interval, as you are using several drugs which can cause prolonged QT interval. And other things, as the problem arises, you may attend to it. Linezolid is another drug, very useful anti-TB drug, but linezolid also can cause optic neuritis, hematological complications. So even if you plan to give linezolid for 18 months, sometimes you may have to halfway stop linezolid and go for an alternative. Monitoring, you will do monthly sputum cultures and treatment continued up to 12 to 18 months. If the patient at 6 months of treatment not responding, you will consider it as XDR patient and you will investigate. Now, if the patient is clinically improving and if bacteriological clearance is not seen, you might consider a co-infection with MOT, mycobacteria other than tuberculosis. Cure from monthly sputum samples, and you are supposed to have 4 cultures in the continuation phase to be negative. What we do is every month we do 2 cultures, and if we have consecutive 4 cultures negative, that we strongly believe that the patient is a cure. But if the culture becomes positive towards the end of treatment, then you have to wait till the patient becomes another 4 cultures negative. Treatment failures, patients positive, cultures are positive at the end of intensive phase, or they are reversing the sputum negativity, again reverting back to positivity. Or if your treatment is stopped due to any side effect, that also considered as a treatment failure. You may have to have an alternative regime. And thank you. That's about all I have to say here.
Thank you for that very complicated lecture which was made very simple. Do we have any questions? Be assured that's not that simple that they go through. Any questions? Yeah.
Yeah. Thank you, sir, for your excellent outline about this hard topic. MDR-TB was not an issue in children, actually, but recently we had a child, 13-year-old, a few months ago with rifampicin resistance and transfer to Valisar. And yesterday also we got a report of rifampicin resistance in the gene expert, RR positivity. So what do you think, sir? What is the reason for the kids are having this positive? And what's happened to that child also? I just want to update me. Is it really they are having the MDR-TBO because of this only the genotypic resistance?
Well, generally when you get a expert MTB RR positive, as earlier Amit also mentioned, that we have to take it seriously. It's not it's specific. The specificity is also high. But generally, because we are doing in several places, we generally tend to repeat the test again. And if you get another positive, of course, we consider it as RR. And while the patient is awaiting INH and quinolone sensitivity testing, we start with shorter regime. If the patient is fitting into the criteria for shorter regime. And while on this, we will be investigating the patient for further cultures, and depending on the culture results, we might change the treatment later on. But if you have RR twice positive, I think we have to take it seriously. That child is on treatment now, for sure.
One question, sir. Now, I know that you've been through this MDR patients for the last 10 years, good 10 years, you've been dealing with them. Now, how often do you see primary MDR patients, like, patients who have acquired from another MDR patient, or do you, the cases that we detect 20 odd per year, are they isolated cases, or are there cohorts, like, do you get the whole family is getting affected, or whole workplaces? Do you see any context?
Yeah. Not to tell you, I have been doing this job now since 1994, more than 10 years.
Yes.
Yeah, right. Now, thing is, we don't see so many clusters, as you say. We see occasionally 1 or 2 patients coming, but it's not a regular event. We see all this. Those days we were seeing all the defaulters and patients who were treated several times. We did not see very lot of primary resistance those days. But now with the gene expert MTB being available, we detect several primary RR patients and MDR patients.
Thank you, sir. Dr. Shantpur.
Thank you, Bandhu, for the excellent talk. And I've been commenting, sharing the thoughts with the rest of our colleagues that Dr. Bandhu Gunasen is one colleague who never say no to any of the talks. We never given at the task of delivering a talk, even at a short notice. My question is, now I remember as a senior registrar, we were encountering patients with many side effects, including people gone totally deaf with MDR regimens and all. Now these days we don't see that kind of complications. Any thoughts about it?
Yeah, because now we are doing away with quinolones. Amino glycosides. That's the main reason. But even before this real longer regime came into play, whenever we had problems with amino glycoside, we tend to change the drugs. During, I think, last 5 to 6 years, we were changing the regimes and using different, because bedaquiline, before WHO recommendation, bedaquiline came to the scene. So we were using bedaquiline before the standard WHO recommended regimes came. I think that is the reason why. But those days, as you said, just until the patients were totally deaf, we could not do anything. We just continued with the amino glycosides.
Thank you.
Any other questions? In the absence of questions, we'll wind up for this talk. Thank you, sir.
Thank you.
Now I invite our last speaker, Dr. Shant Pereira, Senior Consultant Respiratory Physician, National Hospital Respiratory Disease, to talk on the challenges we face on TB clearance for travel and employment. Over to you, sir.
Thank you, the college, for having these talks on World TB Day program. And first of all, I would, this is an important topic, I thought, for selecting for the program. Why selected the topic? Never considered even by the respiratory physicians before. And as you all know, over the last year, probably, there is a sudden increase in the outbound people movement from this country. And we see more and more people who are faced with multiple issues of rejection at TB clearance when they go for their medicals. 22 years ago, what was my own story when I first went for an overseas training in UK? I remember somebody told me to take a chest X-ray of your own. Since I was a senior registrar of Valisara, I went and got a chest X-ray done. And we had the facility of getting that labeled by a lead pencil that we had the good old days. And it carried my name in full with initials. And I got it reported on a printed document by our own radiologist. And at the same time, when I landed at Heathrow, and there was one colleague of mine who was a specialist registrar in anesthesiology, and he had been living there for 1 year. He carried his own X-ray that was put in can you remember this old days CT reports of NHSL, where the blue-colored, kind of an envelope, handwritten on the back side of that envelope. And I was cleared at the immigration. He was asked to wait. He was told that you have to go for a chest X-ray now. And he was refusing to saying chest X-ray are not good for my health. Repeated chest X-rays. And he was refusing, and it dragged on. And finally, the immigration medical officer had been called in. Finally, he has to undergo the chest X-ray. So we were not having the proper time of pre-departure medicals. It's the same now. Now, few real lifetime cases which I have met, and one Mr. Nissanka, somewhat businessman here in this country, and he wanted to move into UK, followed the course in caregiver, and got involved in working in some place for 4 months in Gampa. And finally, after spending so much, and he was barred from going, saying, your medical is not good. Mr. Shanta was just having a small time transporting here and couldn't do anything, and got a job in Dubai, failed again. And as instance of one Mrs. Agnes going to Italy for the baptism of the newborn child, and Mrs. Shantimala going to Australia to assist her daughter in confinement, and some Dr. Samanthi. Both the parents, Samanthi's parents were trying to go to UK because the grandchildren started missing and playing around and having lots of traveling time there, because in the winter they are moved in. And Mr. Joseph, who look after the grandchildren of their son, and also Mr. Jerome, as usual thing, to move into Canada, thinking for joining a master's degree, thinking of settling down in Canada. So this kind of stories we hear every day by day in and day out, and being rejected at the medical. Many came with the plea, doctor, please do something. We waited so long and spent so much of money, and now this is what we are facing. Why there is a sudden rise in outbound migration in this country? Is it just a wave of change, thinking pattern of the youngsters? Are they tired of looking for the silver lining not seen for the decades in this country? Is it ultimately people are not happy to live here, saying that මේක තවත් ඉන්න හිතන රටක් නෙමෙයි, although we expected. TB clearance may be required for employment, long stay travel, and TB clearing is a major component of the pre-departure medical clearance. And when the travel is, it becomes mandatory when the travel is for a long stay, and it is from a medium or high TB prevalent country to a low TB prevalent country, and mainly done to detect active TB. In some instances, it has gone further step beyond, especially in the Western countries. I hear the story of one of my surgical colleagues who had gone for 6 months, job in UK, and tested for LTBI also, and offered whether you want to take LTBI treatment or not. So reason for doing screening, why you do the screening in this country for employment purposes, also for public servants when they go for their confirmation be in the service, and this is to detect active TB among the state employees and to protect them, the general public at large. And for at recruitment itself for police and armed forces they do, and also here it is done for inbound migrants also. It has been started for the Chinese migrants, in the Indians and the Bangladeshis who are coming here and staying for long. But in the overseas travel, to prevent those with activity entering their lands, to protect their communities, and also to protect the risk groups like patients, children, or the resident inmates. Is pre-departure medical screening a good practice? It certainly is. It detects infectious disease, prevents spread across the globe, and detects other non-infectious disease, allowing to decide on the fitness to work, and allows them to treat before travel as well, and also prevents an additional health burden for that receiving country. Then why is it an issue here? There are unexpected outcomes. All this, so much of tedious preparations they are made. And also many false negative rejections. Is it due to, as Dr. Madhukar said in the morning, is it overdiagnosing, or just because it is done by unsupervised or unqualified people? Why people migrate globally? There may be economic migrations for low income, unable to increase their productivity in their country, and high inflation rates and high taxation started in this country as well, and social migration for education and better recognition of their knowledge and skills, and corruption and fear of their future for their children. And also there may be reason where you have political migration due to undue political influences, deteriorating human rights situations, maybe war, and environmental migrations also. I remember few of my colleagues who were British when I was in training there. They said they are migrating to Australia because it's a better weather. Maybe it never thought of by Sri Lankans here, just for the better weather we are going to another country. But where do we stand here in Sri Lanka? We may be certainly moving for employment, education, just to settle down, or join with their families for the reasons I have earlier said as well. But remember, we had a 3-decade-old war. There have been people movement from this country to the west, especially from the north and east, and to those who cannot go to the west, even to the neighboring country by boats or other means. But rest of the country, rest of the 2/3 of our country, people did not even having this terrible war. Did we migrate in these numbers? So that is something for us to. So those who are saying, criticizing people migrating and all, and just for their own good, and even with war, we worked here. Even we worked in these difficult places as doctors also. Is it always just people moving to greener pastures, forgetting their own roots here? ඔයගලන්ට දුන්න නිදහස් අධ්‍යාපනයත් අමතක කරලා, everything අමතක කරලා, ඔයගලන්ගේ අම්මා තාත්තාත් අමතක කරලා, going like that kind of story. But people don't understand. Those who criticize, there may be another Kandulukata or the story of tears. And you need to remember, you should not forget that the months of thinking somebody discussing with the family right before arriving at the decision, with the intense fears of safety of the family left behind, the safety of the person living alone overseas, and the financial insecurity if it fails, and living alone somewhere, and medical issues we are going to go with, and what kind of very, very frequently we come across, even for just simple asthma people, how then the children are going across to colder climates, how they are worried about the asthma coming back and kind of even. And please do not forget the loads of preparations done on the travel, the home front, and the employment requirements like the right to practice professionally in other countries and the documentations and overseas living issues, the picking up at the airports, accommodation, earning, education of children, medical care, extreme weather condition preparations, and banking arrangements, so on. And amidst lots of constraints on foreign currency to be taken over shores. And the huge amounts of money you have spent. Just to consider effects of rejections after the delayed medical clearance, to enable to start employment and losing the job prospects, enable to start education, missing semesters, and many of your family members, if you are going with the families, and one member getting rejected, these are the stories we see every day. And the whole family cannot move. And cost of repeat medical testing, they say that any testing will take up to 40,000 rupees. And they are already financial strained people. And looking after, they are losing the opportunity to join the family for a memorable event like baptism or whatever. And they are unable to be a help for the family who are in need, and also mental and financial strains that results. What are the countries where screening is mandatory? The Western countries, including Australia and New Zealand, and the Gulf countries, and in the Asian bloc, Japan may select for different height burden countries, including Indonesia, China, and there may be other reasons also why they do this kind of screening. And Singapore may do a residential on-bound screening. I don't know what happens in Korea and Malaysia. What are the types of screening? It could be a pre-departure screening most often, and it could be a residential on-bound screening. Or in some countries, they may request both. I've seen patients who have, they are not patients, people who are, got the screening here, got okay, but when they travel overseas and the Middle East country, they have been rechecked and sent back. So what happens at pre-departure screening in Sri Lanka? For the Western countries, we have the IOM. It's an International Organization for Migration. It's a UN agency on migration, which is in something in Horton Place in Colombo. And for the Gulf countries, they have something called GAMCA Medical Centers. That's the Gulf as Approved Medical Centers Association. It has the outlets in the screening centers at Colombo, Kandy, Kurunegala, Matharan, etc. And they are given different validity periods are given for their this documentation. They first get an appointment, maybe online. It has a validity of 21 days only. Once they pay that 40,000, if they cannot get a clearance within that 21 days, that they have to pay again. If they get a fit report, that they have to travel within 3 months. If they get an unfit report, a travel ban is there for a Gulf country for 180 days, unless it is changed by the same center or a different center. So at a TB screening, what happens in a government facility? We do something called the clinical, radiological, immunological, and microbiological evaluations to diagnose active TB. What do you call this? Clinically, the 4 symptom screening, the past medical history, the contact histories, and various risk factors we will be going through. And we'll be doing a chest radiograph and maybe we do a Mantoux test and a sputum direct smears for AFBs. And where relevant, we may go with advanced testing like HRCT or quantiferon TB Gold or AB cultures and gene expert where relevant. What are the responses these people get after this pre-departure clearance testing? Some places they issue a proper report, a printed report, versus some people just get a verbal statement saying, "Where the medical fail, can't go," or "can't go, X-ray not good," or maybe medical fail, can't go, but if your doctor says okay, we may consider, but come in within this 3 weeks time. By that time, there is only about 2 or 3 days left when they arrive at a different consultation with us. So what is worrying in this, with this the clearing centers, the steps in clearance, basic or advanced, clinical clearance, do we have real qualified medical officers at these places? Radiological clearance, do we have a proper equipment? We have seen horrible X-rays at very low quality appearances with lots of movement artifacts like blot pictures, and based on that they get rejected. Or they say, or do they have the qualified radiologists as they put on the stamp or whatever? And when there's some places they may do Mantoux tests, we are not to do Mantoux tests for a screening of active TB, because Mantoux is an immunological test. And do they have qualified healthcare workers, or performing issues, how interpretation issues as we discussed in the morning? And for microbiological also, sample collection and all those things matters. If you compare, with all respect to all the places where they do the proper screening, if I compare the IOM versus the GAMCA, if I go to the IOM, the screening is done by a qualified medical officer always, I know, because one of my medical officers also applied for the IOMs to become one of the medical officers there. They went through a tedious process of screening and checking, getting references, including from the current consultant and all. And with that, she was released for a particular period from the Ministry of Health. She can decide whether to stay or come back to the ministry, that kind of operation. They have the good quality X-rays. Reporting is done by the radiologists in overseas, not by ours, from Manila, Philippines. And they normally don't do immunological tests and microbiological tests where relevant. They normally send to, they used to send to NTRL in Valisara, but during the COVID time, they started rejecting all the samples which are not cleared for COVID. And probably now they are sending to Manila. I don't know where they are sending at the moment. And final evaluation, they get a printed report. And saying if it is negative, they say negative report is issued, and we are going to go ahead with further testing with microbiological studies. Because you cannot say on chest X-ray, this is active or old TB at that point. What happens in many GAMCA centers, but not all, some of these places, there are concerns about the medical officer who is screening. I remember when I was a Kurnagal chest physician, I have seen reports issued by one particular medical center where they have the sub-branch at Kurnagal having the same name at the bottom of one doctor on both places. Somebody put a signature like a Coca and a signature and the same. I was thinking how this person is appearing in both places at the same time. Right? So, chest X-rays, again the problem of equipment was there. I was wondering whether they have really good radiologists to report. I was discussing with our own radiologist doctor at Valisara. She was saying, you may be correct, Ashant, I also thought about it, because one of my own senior registrar's signature had been there on one of these reports of one of these GAMPA. And he has given a referral letter to another radiologist asking to do a ultrasound abdomen or something. And she had been wondering, a senior registrar who is very good, very, very competent one, why this person has given a referral to another radiologist outside to report on, do an ultrasound scan. Then she has called this particular Dr. SR and asked, "Wage signature එකයි rubber stamp එකයි තියෙනවා. මේක ඔයාද නෑ මැඩම් මම නම් ලිව්වේ නෑ. මම එක දවසයි දෙකයි යතන්ට ගියේ." So microbiological sputum maybe is usually not done. And Mantu test. There was a concern about Mantu also when I was working in Kurunegala. I saw Mantus done once, patient doesn't appear for the reading, done twice. And I saw that there have been lots of deficiencies in Mantu placing and reading even at our own hospitals and district hospitals. So I called for a workshop through the district DTCO, TB control officer, and we arranged a payment also through the campaign. And I invited these places also to come and join us in this training program. They sent 2 people from one of these places where they do this Mantu. And to my surprise, they were not even healthcare workers, just 2 boys came. They said that we are the ones who are doing Mantu. And not even any healthcare qualification. And what is the final evaluation outcome? They normally don't give a printed report. When a negative report is issued, mostly an alternative is not given also. So this has been a problem. Now, if people are facing issues just because somebody is not qualified, not having equipment, not knowing what to do, just saying no to some people just because of one odd reason, it's a crime, I thought. And it is coming, and we all chest physicians are facing this kind of cases every day in our practice. What are the issues that may arise? They may not be thinking. Fear of losing the job or educational opportunity, fear of previous undetected illnesses. Now they say, you are a. And rejections may be, sometimes they say the rejected applications may be shared to this GAMPA group, preventing all chances of clearance in the future. And they have been asked to go for repeat payments of 40K again. Costs of repeat private evaluations come into a different set of investigations, or adding further economic constraints thereafter. And when they come to us, there are other issues after evaluation what we get. If they come to us after a rejection, we need to counteract another, within inverted commas, specialist report, whether it is a qualified person or saying that X-ray is not good. And non-acceptable acceptance of a properly evaluated report given by us, going through a repeat X-ray, another radiologist reporting, and we go through the TB screening as done in a hospital. And even if we give a letter, we also do some mistakes. We don't properly identify the client as that person. We may not be putting the passport number or the name as appearing in the passport. Those are very, very important things. And when they come to a government hospital, do we give a printed report at any time? We give just a handwritten chest X-ray report, and most of the time it is very difficult to read also. And sometimes even if you issue a proper report with the printed form, they may ask, the medical center who has rejected may say, "Meka dila hariyanne," that countries you have to get it translated into Arabic language. That happens recently. I had to get it on printed this paper and to go for a translation. Few suggestions. There is a role of professional agencies. Medical Ministry of Health, we have an agency or department called Private Medical Health Regulating Authority. And the SLMC has to have a check on them. And the MPTCC, National Program of TB Control, the SLCP, the College of Pulmonologists, the clinicians, any other clinicians who would encounter this kind of patients, and maybe that the Foreign Employment Bureau and visa forwarding centers. The ministry and the SLMC can have a check on the screening centers. We need to do some capacity building for the screening agencies, and we need to treat the migrants respectfully with compassion. We recently saw on social media and at VFS centers or whatever places of visa issuing centers, these people have been called by names, calling them with nicknaming them as, I don't want to tell it in public. And we need to empower the public also, educate them what happens at a medical screening, and to carry out for them to advise to carry all past medical notes or treatment records or chest x-rays even. Even at IOM they say, if you have your previous chest x-ray and this dot which is appearing, if we can upload that also to Manila, they may consider it as an old change and you may not have to. So I've been telling my senior registrars, get a chest x-ray now and keep it for yourself. And when you go for this IOM evaluation, carry that along with you and say that you have been having the same old x-ray and it has not changed. And also one suggestion is to go for dummy screening at another place. Maybe going to another doctor and get all the tests done they normally do for not only the infectious disease screening, including syphilis and all this HIV and typhoid and various things they normally do. And for the specific organ screenings, for system screening. And also when they have troubleshooting, whom to contact. And think again, whenever they come to us, they are our fellow citizens, whether they are coming to your place as for a medical or at a visa forwarding agency or at an embassy or whatever the place, treat them properly. They have taken many risks. They are not just going for fun and going through immense difficulties. And we as respiratory physicians, they come for your opinion, thinking that there's a newly found disease. Try to help them to exclude or treat and go beyond your call, issuing a professional report where applicable to get a medical clearance. Finally, I would remind you all and the public or others who are listening from online, anybody who has a family member who have gone abroad knows the pain of not having them around with you. Just think if you have had any experience. I'd like to end this talk with this thought-provoking song relevant to the topic sung by C.M. Jayaratna. Okay, thank you.
Thank you, sir, for that lecture. Do we have any questions from the audience? Because this is a topic that is happening. I think we respiratory physicians go through this big time, but I guess even the medical students have this problem because people must be walking into your house asking for opinions.
Thank you, Ishant, for bringing up this very timely topic, and we are facing a big load of patients, not applicants, coming with this situation. They have a classification system of X-rays, especially the IOM ones,
yes,
in which majority of the time it is pleural capping, irregular pleural lining, which they associated with pleural disease. I don't know whether there are any studies. There must be some international studies done on this, where how like pleural capping or irregular pleural outlines in a young person is associated with latent TB or active TB. There must be some evidence, otherwise they will not have that in their thing. So mostly the rejections are on like that, irregular
yes,
pleural lining, apical pleural capping, outlines like that. So they may have to undergo all sputum examination, as you said.
yes.
8-week delay with 2 weeks processing, about 2 months delay.
Exactly, Amit. But they give this reasons for rejection, at least for them to see, and for them to carry to another doctor and ask what's wrong with my medical report. But it is not happening in the other places. They just says that your X-ray not good, medical unfit, and kind of the response. Yes.
This is the problem because some radiologists themselves say unfit.
Yes.
They would say unfit and.
I remember when I was the president of the College of Pulmonologists, I raised this problem because even at that time, that was in 2015, and I raised this problem with the ministry also when at that time Dr. Kanti Ariratna was the director of the campaign, and she was the person who was in charge of the private sector regulatory authority. And I remember going to one of the meetings at the GUH in Fort with herself and Dr. Kirti Gunasekara. And we called all the, I think Geetal was also there. We called the agencies as well. And we came to know that when they say no, and when detected when they say yes and they have given the clearance, and when they do the clearance again at another country in the Gulf, and if it is become positive like, they are fined $1,000 or something like that.
Yeah, $20,000, sir.
So I was wondering how they can fine them unless they have a contractual obligations with this.
They
agencies.
have a contractual obligation.
Yes.
This is what it
That is, they say that they are paying these people.
Yes, they do.
Yes.
Because I think the problem is with the supply and demand. When there are so many people from Bangladesh, India coming to Saudi for these menial jobs, they don't care about rejecting somebody on the least of issues, whether they have a bullet in the lung or whether they have a TB in the lung. They don't care. They just say normal X-ray or you're out. They don't want to be bothered because you know that your sensitivity of excluding TB is fairly high if it's absolutely normal. So whereas in IOM ones, it's a different parameters where they want you to go through that and get it. The key is the time, because the TB being something that you can't exclude so quickly, it takes that 8 weeks. So if you're going to a European country, might as well apply for the medical early and then get that sorted. Well, recently I think there was a problem of getting the dates for the medicals. So then you get really stuck.
Yeah, another small take-home message for budding consultants. Whenever you have a seal, always keep it in your custody.
Exactly.
Don't hand it over to anyone, because now this is a multi-million business. People can abuse your seal.
Yes.
Or don't allow anyone to cut your seal. Have it in your pocket and use it and take it home.
And when you start your career at various channel centers in locally, when you're going to practice, they would come and say, "Sir, ma'am, feel like a kapi kapla denna." They will be. Don't get them to cut your rubber stamp. Why can't you get a rubber stamp cut for yourself and keep it and travel and take it along with you whenever you go? Don't leave it at the channel center places. They may misuse it in different reasons. And when you are going back also from your overseas training after your acting appointments, I reminded Dr. Malinda also, remove your seals from our clinic premises and when you leave, because they will be using it for various other purposes.
Just a comment. In our own case, when we have people coming to our country, where we are high burden MDR TB countries like India, China, Bangladesh, all these countries, we do their medical here in Sri Lanka, not before they come to Sri Lanka. Right? So we have argued this on many occasions, because once they come here and they apply for resident visa 6 months, or they have short stay visa, their medicals are done here. So we have detected many people with many pulmonary involvement due to tuberculosis, and these we must remember from MDR countries.
And also, this became a political issue because some countries didn't want their people being screened there when they came here. But in our case, when we have to send somebody to another country, we have to accept their terms and do the medical. The other part is that these medical agencies, they get paid for what they do. Actually, they get paid by the Gulf countries and the receiving countries. and they keep that money and ask the clients to pay as well. So there is a slightly slimy deal going on here as well.
That is why they can, I mean, fine them if they send a patient with person with TB.
Yes.
Otherwise, they cannot fine them just because they have done the screening and they missed a TB case and found later on.
No, exactly, sir. These different agencies have agreements with the Saudi country. So if one of their sub-agents make a mistake and then send, still the main agency will get fined for those $20,000. And earlier they used to just pay it off. But lately they can't afford to pay also because you don't have US dollars to pay. So
no, one guy when I was working in Anurad, Surnagal, he said a small time one, he was doing a sub agency, like he gets a smaller number of clearances, and he said, "Sir, make a mara salli, sir."
That's a lot of money.
One other question, sir. These refugees are here in around Nigambu area and all. I don't know how they have been screened. Like there are a lot of refugees from neighboring countries, few neighboring countries.
See, that's what Dr. Amit also said, that there is a system to screen them. I don't know, during COVID, just before the COVID, they started screening them, these inbound migrants as well. I don't know, with COVID, even our own screenings went into a problematic situation. We could not do our own screening for our own patients as well, and we dropped in our case decision at Sri Lanka as well to 7,000s from 9 to 8,000s. And I don't know whether it is properly happening the way it has to be.
Now that it was brought up, I think we should stress again that there is a real possibility of MDR patients coming to Sri Lanka from the neighboring countries, because the MDR rates are not like that in Sri Lanka, in India or China or in any other Southeast Asian countries. We're talking about 5% up. So when you see a person who had been abroad, I think that was stressed in that lecture by Dr. Bandugunasena also. When you're looking at people who had been in high MDR regions, think about TB and think about MDR TB also, and then unless you do a gene expert or a culture, you will not really catch it, and then they could give it to somebody else in their country. Yes, sir. So since there are no other questions, shall we wrap up the session? And I think I'll have to give the...
Yeah, sure.
Now I invite Dr. Geeta Pereira, consultant chest physician and past president of Sri Lanka College of Pulmonologists, to deliver the vote of thanks.
Dear friends, thank you to all of you for attending this event. Being chest physicians, respiratory physicians, pulmonologists, whatever you call it, TB is our first passion, first love, although we do many other things. So I take this opportunity to thank, on behalf of the college, the TB assembly. We have an assembly of interested respiratory physicians with Dr. Eshant Pereira for organizing this event with a lot of passion and a lot of enthusiasm. And also our sponsors, SoftLogic Pharmaceuticals, for readily agreeing to sponsor this event. That's why we didn't charge you. There will be lunch served as well after this. And the speakers, all the speakers were very cooperative and extremely happy to present at this session. At very short notice, some of them, Dr. Amita Fernand flying in this morning, Dr. Bandugunasena in the spur of the moment, Dr. Prof. Madagedara coming all the way from Kandy just for this lecture. So it's fantastic to see this kind of interest and cooperation with the college in making things happen. And this is all for the education of the postgraduates and the others who will one day become respiratory physicians. And I thank all of you for attending. I hope you will attend other events organized by the college as well in future. And hopefully we'll see some of you among our ranks in the years to come. Thank you very much.
So now we have come to the end of the academic program of World TB Day 2023. So thank you everyone for the participation and their kind cooperation. Thank you.